MRD positivity. I mean, by the standards, it is more than 0.01%, means 1 cell in 10,000. But if you have more than 1 cell in million, I don't know. Anyone want to comment?
Yeah, maybe you can add and refer to some of the available data on MRD assessment by NGS post-transplant, where it was shown to be predictive of outcome, and it can give an earlier idea about patients who are going to have a real positive MRD. It can be detected as early as 30 days, where in other patients, or PCR even, you need to wait until like 60 to 100 days. So somebody is going to intervene with or intervention, so that will be a good tool to use for assessment before going to transplant as well. If MRD is positive by NGS for ALL, to at least make sure he's really an MRD negative, just because the evidence we had activity before transplant. To modify treatment based on MRD NGS negativity in the upfront ALL treatment, I don't yet have good evidence, and maybe if Dr. Stefan Hunger is with us, we can hear his opinion. Recorded? Okay.
Yeah, just a small comment about the NGS, because I will cover some part of it later on. For the current clinical trials, so positivity of NGS MRD versus negativity, they may allocate those patients for TBI-free regimen if you are MRD negative. It's a trial by a specific group in US.
Okay, we'd like to thank the speakers for the very nice presentations and the fruitful discussion. Thank you.
Thanks, speakers. Please, Dr. Yasser, Dr. Walid, Dr. Badr, will stay in the theater.
Bismillah ar-Rahman ar-Rahim. We are going to start the second session today. We will start with the first speaker, Dr. Mohammed al-Shahrani. Is a consultant engineer of pediatrics and oncology at Prince Sultan. And he did his fellowship at sick children at Toronto. Dr. Shahrani is going to talk about the indications of stem cell transplantation in relapsed acute lymphoblastic leukemia. Please.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everybody. Thank you so much, Mr. Chairman, for the nice introduction. And thank you so much to the organized committee for inviting me to participate in this prestigious conference. And I would like to take the opportunity to thank Dr. Muhammad Amin and to thank all the people whom they are behind this success, and congratulations to this great success. And also on behalf of the Saudi Society of the SAFOS, I would like to thank Al Musa Group for the. So, I have been asked to talk about the option when ALL relapse, when do you do bone marrow? This is my disclosure. I have nothing to disclose. I'll take this morning. Okay, regarding the acute leukemia, this is for the residents, is a malignant neoplasm of B or T lymphocytes identified by the controlled proliferation and accumulation of the immature lymphoid progenitor cells in the bone marrow and on the other lymphoid organ. So as you know, the ALL is the most common pediatric malignancy. However, 70% of the leukemia affect the age between 0 to 14 age, and also it is the most treatable disease, and the majority of the childhood cancer is now cured. So the survival and the cure rate has been improved drastically on the relapse disease. About 10 to will relapse, and unfortunately the outcome with has been disappointed because most of this intensive treatment approach have reached the limit of tolerability. And when you look to the outcome, it's plateau, 35 to 40% with the traditional approach. 20% of the patients failed the frontal therapy. However, the relapse ALL account for the more death from the cancer in childhood with another malignancy. Historically, when we go back before 1915 and 60, the palliative care was the only case, the care available for the children with but with the advance in the treatment regimen, the survival rate has been increased dramatically since 1980, and the current 5-year survival, it reached up to greater than 85%, and some disease it reached to. So the success of the achievement is brought through the implement of risk stratification, in addition to the combination of chemotherapy and also prophylactic chemotherapy in this relapse, as well as all the study group, including and clinical research. As we know, the relapse will be based on the diagnostic feature as well as the early treatment response finding. And further prognosis comes from the refinement of the relapse. They benefit from a specific target therapy, in addition such as the mutation, white blood cell count, immunofluorescence, cytogenetic, and molecular. And this is the risk group. This is published by the COG, where they have the trisomy for 10 and 17, male response, where they divide it into 3: low risk, standard risk, high, very high. of MRD, CRA failure. And the cure or disease is the interaction of the disease as well as related factors. And when we apply the treatment to the same patient, because this we can expose them to either we are treating the patient, over-treat them, or under-treat them. So, and the tumor and at the early course of the treatment. And when we intensify the chemotherapy, we know the of the intensifying the chemotherapy, the early of the treatment, it can have more rapid elimination of the sensitive cell, prevent of the and treatment of resistant cell. And these are the most common treatment approach for children with relapse. Usually we start with reinduction regimen, followed by continuation therapy, and the patient either will go for with radiotherapy or without radiotherapy, or the patient will go to transplant. And to optimize the post-remission, this will be depends on the timing of the relapse, site of disease, recurrence, and disease immunophenotype. And recently there was implemented the MRD recently with the assist MRD at the end of reinduction post-treatment, and this has been correlated with the outcome. So the improvement will be based on the cytogenetic molecular marker and the response to therapy. And when they optimize of the chemotherapy, either to reduce the toxicity for patients who can be intensity, or to intensify the chemo for patients whom they can remain at high risk of relapse, plus monitoring the response of the MRD, better salvage option, including transplant and good supportive care. The timing related to the study group will take the BFM and COG. The BFM and COG, they divide the timing of relapse very early and late. The early were defined by BFM if they are less than 18 months, less or equal 18 months from the initial diagnosis. The COG less than 18 months from the initial diagnosis. This is very early. Early, if initial diagnosis to 6 months after completion frontal therapy, while the COG less than 36 months from the initial diagnosis. The late, more than 6 months after completion of the frontal therapy by BFM, and the COG more than or equal 36 from the initial diagnosis. And this is the scheme to show treatment has been published in 2012 in American Society by Elizabeth, where she divided this group to two groups, high-risk group and low-risk group. And they will, the high risk where the patients, they are relapsed at early lineage marrow and have any teen relapse, they will randomize them to both chemotherapy or chemotherapy with novel agent. And they will assess MRD after H block. If the MRD negative and their patients are in early lineage or early relapse, they will go for transplant. If the MRD negative and he is early and this is high risk, they will go for transplant. If the MRD positive, they will go for bridging study and they will go to to transplant. On the other hand, here the late lineage, they will divide into two groups, chemotherapy and chemotherapy with the novel agent. They will assess MRD positive. So they will not consider as low risk, they will be at high risk, even if they late marrow and MRD early with the isolated extramedullary relapse, they will go to for transplant. MRD negative and he late MRO and MRD negative, he will go for continuation therapy. So the question, when do we do the bone marrow? We know that the research defined the role of bone marrow by establishing the indication and identify the emerging indication where the BMT may be initial. So the medical decision, we know it is very complex to decide for this patient to go for transplant, beside the other factors such as the patient overall health, performance status, comorbidity, disease risk, remission status and the response of treatment, as well as graft and donor resource. And the patient who underwent the stem cell transplant after CR1, he will be better outcome compared to those patients who went under transplant after second or third. Besides the other prognostic factors such as younger age, patients who have TBI condition or total body irradiation, patients who use of HLA identical sibling donor, and the occurrence of acute graft disease. So these are the possible indications for transplant we'll take the CR1. So these are the indication. Primary induction failure, patient who had basis MRD after consolidation, Philadelphia positive chromosome, I will come back to that one. Extremely hyperdiploidy, infant with AML rearrangement less than 6 months with high risk characteristic. Any patient newly high risk CR1 group, not yet being used for treatment assignment, early T cell, because T cell allele lacking B allelic TCR gamma locus deletion, and that has been mentioned by Dr. Walid, by Dr. Stephen and Dr. Yasser. Those whom they have genetic problems like IKZF1 deletion, JAK1 and JAK2 deletion, and the deletion of CDKN2A and B, and gene cluster groups are the indication for CR1 transplant. What about CR2? High-risk patient. The high-risk one that is the one who have isolated marrow relapse on treatment or with 6 months of completion of the treatment, or patient has combined marrow and extramedullary relapse within 18 months of the diagnosis. The other one, the intermediate risk, patients who have isolated extramedullary relapse within 18 months of the diagnosis, that means he is in early relapse, or patients have marrow relapse, whether isolated or combined, the marrow than 6 months after completion of treatment, and he has still MRD positive after the induction. And the third group, CR3 risk group, any second or the marrow or isolated one positive as indication of transplant unsensitive response.
University and subspecialty fellowship in cellular therapy and bone marrow transplant. Dr. Muhammad, he will talk about bone marrow transplant in
And really, it's an honor to be here. I really apologize personally because I could not make it yesterday. Thank you very much for the day. The talk will be also kind of a continuation of talks, but we'll focus mainly on transplant leukemias. Disclose, but there'll be an introduction, and followed by ALL, AML, APL, and some of our hospital statistics in leukemia transplant. So the first thing, it's very clear for the audience that allotransplant in malignant disease, or particularly in leukemias, work by two mechanisms: the curative effect of the conditioning regimen and the immunological effect of the GVL effect. The second part is when to transplant. So let's go with ALL, and this is a summary of Allah Ta'ala Dr. Shahrani. So this slide, it's the same actually reference, but we talk about around 8-10 years ago. Is it different? Is it changed? Is it going to change in the current advances and CAR T therapy and all that, especially when we talk about CR1? So I'll not talk a lot about that, but it is a summary in this figure. So if you look at BALL, if you look at the side where there's the infant ALL and CR1, there is a specific category where the ones who are less than the age of 6 months with high count with KMT2 rearrangement. But nowadays there's a more newer data about the Japanese approach and the interfant group where we are going back to transplant with CIMSO and infant ALL again. So that's something that's going to happen. The second part is the PH ALL and hypodiploidy and induction failure. Overall, this is something that's been historic and all the time, but this currently it's the only indication if they are positive at end of consolidation. So if you clear your PH, let's say after induction 2B in PH-ALL by the ISPAL group or by the COG, then you're no longer a candidate for BMT and pediatric Philadelphia positive ALL. The second part is the hypodiploidy, which is not now anymore an attentive category for BMT in the presence of CAR T therapy. So really hypodiploidy, if they respond to chemotherapy, then you continue your chemotherapy. If they relapse, probably BMT is not the way to go, then CAR T has a better outcome from the preliminary real world data of what we hear. Now, if you look in the second half of the paragraph, there are different 2 or 3 categories in CR1. The first one is the IKZF plus. So when we mean that Icarus mutation combined with either the CDK2A or PAX5, but without ERG mutation. So these are the definitions of IKZF plus, which is actually been adopted by the European and the BFM group. The other category of patients they do very poorly are the translocation 17, 19. They are very rare, but these are the ones also could be considered, and they do very poor. And then the last category is the positive MRD after end of consolidation, where here it comes when you need to think and decide, is it a candidate for BMT or not? And that goes later on one study that I'm going to talk about soon, but this is only about hypodiploidy, that COG is no longer thinking that they are the best, or like SCT in CR1 did not show any survival benefit for hypodiploidy. So it's not a get-go from the beginning. And that's confirming the earlier studies from St. Jude, actually. So CAR-T now is good. Now, how about consolidation post persistent MRD post-consolidation? So here we have to think from the beginning, what is the category of the patient? Is the patient from the start with is an NCI standard risk group or NCI high-risk group? Because if this is a patient with an NCI high-risk group, that means that the patient already had a high-risk induction followed up by a high-risk consolidation, and those patients are high-risk and still positive MRD, then those are the patients that they are candidate for transplant or CAR-T. So you put them in remission and then take them to BMT, or you go for the CAR-T, which is a current open study at COG of that category of patients with 0.1 MRD after consolidation as a high-risk patients. And this is already published by the COG, that you don't need probably to transplant a standard high-risk patient who converted to a positive MRD, continued to be positive MRD, and you upgrade them to high-risk consolidation. And after that, it depends on your situation after that post-consolidation. Their outcome is different. If you see the standard risk, their outcome is around 70% range for standard risk who become post-consolidation MRD without transplant. So you may actually avoid transplant. On the other hand, if it's a high risk with positive MRD, post-consolidation, this is for sure those patients needs a transplant. And they are salvageable, by the way. So that's why another thing why the standard risk group, when you upgrade them, even a positive consolidation, you don't do that. So this is the summary of this part. For the standard risk group, variable practices. Some people will give high-dose MTX, and then if this patient followed by MRD negativity, they will continue therapy without transplant. But then after intermittence, still the patient is positive MRD, then you give another salvage and go for transplant or consider CAR-T. Now, some groups still use, on those category of patient, BLINA followed by transplant, and some use off-label current uses like target therapy followed by maintenance. Now, switching gear to CR2 and ALL relapse, I will not repeat Dr. Muhammad's talk. So the low risk categorized with no transplant, and the others will need transplant if they go into remission. If not, then you proceed with CAR-T or inotuzumab or any alternative therapy. Now, the European put some categories like the Icarus mutation, the even translocation 119, which we think it's a neutral
risk factor. In the relapse setting, they do poorly, and Locatelli and his group do put them onto transplant list. Now, we know in the upcoming ASH 2022, they already released the abstracts. If you have a look at that in the ALL, you will see also that the cytogenetics and the genetic aberration at relapse time will also affect the outcome, and it might be something that you also categorize the indication of transplant. So the unfavorable cytogenetics at relapse will also impact on your outcome. It is bad biology anyway. Now, what about the indication for ALL transplant post-CAR T? So do we transplant after CAR T, yes or no? So some indications that are really almost like sort of people are trying to agree with, like KMT2 rearrangement, because they have the risk of switching the lineage to AML after CAR T if you don't transplant them, around 20 to 30%. And the other group that advocated to go for a transplant after CAR T and use it as a bridge if you lose your CAR T persistence. And also, finally, the type of the CAR T you use, depending on the stimulating domain, which is 4-1BB or CD28. And the last one is the presence of prior transplant or not, and there are different practices in regard to one. So the TCT actually have published, looked at that. This is the Seattle group, where they checked about 64 patients. Some of them, they were eligible to transplant or not. Some of them had previous transplant and others none. What is found actually that is interesting, just to mention, it's a 4-1BB domain product, so it's very similar to the Kymriah, but we cannot generalize too, because it's an in-house made CAR T. But they found the patients who had transplant that had a better outcome compared to no transplant in a specific category. And that category actually are no prior history of transplant. The p-value was around 0.09, and the CAR T functional persistence around 63 days as a cut limit, whether you go for transplant or not. But this was not statistically significant in patients who had history of prior transplantation. So the current practice, anyone had a previous transplant, you don't transplant them. So let's move now quicker to T-cell. I'll not spend a lot of time on T-cell. It's a bad disease. Unfortunately, there are not a lot of weapons there to target, especially the refractory and relapse ones. But at the end, we try our best transplant, although it's not the best outcome, especially in relapse setting. If you have a persistent MRD, you consider it in first CR1, although this is not actually did not show improvement by the COG group, but the practice of the transplant center will do that. So put the patient to MRD negativity prior to transplant, and this is very clear. If you are MRD negative pre-transplant, you'll have a better outcome. Earlier, Dr. Wali and the group talked about NGS MRD prior to transplant, and you clearly see the ones who are NGS MRD negative have the best outcome. And then what you use for ALL is a TBI-based regimen, and a special category will be the less than 3. We were privileged to be part of the TBI forum study that was published 2 years ago, which, at the end of the day, TBI is still the standard of care for conditioning regimen in ALL transplant. The arm of the infant is still under analysis and follow-up, because less than 4 years old, they were not receiving TBI with encouraging outcome, but still results to follow. You see the difference in this randomized trial difference between TBI-based versus chemotherapy-based conditioning regimen. How about post-transplant care? MRD assessment, immunosuppression tampering, DLI, immunotherapy, and TKI. Those are things that you could actually do after a transplant and initial bone marrows. Second part is the AML. Dr. Ballura already covered it extensively. You could see here the wheel and how could you find, FLT3 plus CYP mutations. And those nowadays, there are people looking at those kind of combined mutations, whether they are not anymore high risk. Some of them goes to intermediate or like a lower risk patients. So how I treat by Robbins et al. Classically, a low risk and intermediate would not go for transplant. If you are MRD negative, the high risk group will go for transplant, and the relapse and refractory also as well take them for transplant. So this has been discussed before. The favorable list, no transplant. The unfavorable list with transplant, and especially if you look at the difference, the red, the inversion 16, the different one, that is a high risk, not the usual one. And then all the usual what we have here. It is also important to mention that the TKD is not like the mutations in the tyrase kinase is different than the FLT3 ITD. So we could look into that later. But this is the outcome in general, and you can always look it up in the AML study, the 0531. And it is clearly seen, GO is the use of GO is in event-free survival is helpful. Overall survival, there is a lot of discussion and debate, but at the end of the day, the intermediate risk did not benefit from transplant per many studies, and it's not anymore the standard of care. However, we need to put in mind that in an event when you cannot assess the MRD, in a very accurate way, you may still consider the intermediate risk as part of the classification in the presence of a match donor within the family as the older practice. But this we can discuss in a discussion. In relapse setting, CR2 is not great unless it's after 1 year of relapse. MRD is controversial, but this is one thing that we always talk about in ALL. It has an impact in AML, but as not much as in ALL. I will talk about it mainly in the conditioning regimen of AML. Most of our centers and maybe around the world will use BuSci for AML patients. Now, if you look at the latest, a few years ago about the EBMT group and their outcome discussion, you will find that, and in current trials, that BuSci melphalan is superior to BuSci in AML in the pediatric group. The number, it's a registry study. We could go back and check. In my center, I still use BuSci, I admit. But if you look at the data, you may be convinced about BuSci mel. If you look down, you'll see that you're talking about 60 versus 74% in leukemia-free survival. In overall survival, there's a 10% difference, 64 versus 76, and they're all statistically significant. On the expense also, you see a little bit of more GVL, GVHD in the BuSci mel group. So this is just to say that some people, it's one of the standards of care that's been used in Europe. And here are the curves that show the dotted line at BuSci mel is a bit higher than the others. Now, saying that, we could argue that if you have a patient comes with MRD positive to you in a transplant setting, I may consider BuSci mel in that category of patient. I'm not saying I'm right or wrong, but this is one of the things that could be happening. The other part is the value of DLI in AML patients as a post-care. And in pediatric, we don't use it as adult. This is a guidelines for adult AML. For us, most of the time, we do not use prophylactic DLI. We usually do preemptive DLI. So if you assess the MRD post-BMT between day 30 and day 60 and it's positive, or if your chimerism is not good, you could go ahead and give DLI after taper your immunosuppression as a first thing. Now for post-AML care, there's TKIs that could be used. And as we know, FLT3 ITD is one of the prognostic, classically in pediatric we categorize as high risk, but also you could find TKDs, mutations like DA35. Those have been already studied in the adults very clearly, that in the Soramen group, that sorafenib is good in the FLT3 ITD, and the outcome as a maintenance post-BMT is useful. The COG at the level of 0531 and 1031 group, they also showed that there is a trend toward benefit of using sorafenib, putting in mind that there are some, and those kind of studies, there is a limitation of interpretation of that. Other agents like midostaurin and gilteritinib, which work on TKDs and not on a FLT ITD, is something that could be considered in the older children, but after discussing with families, but not as a recommendation, as off-label use. And finally, I'll go quickly about APL, which is a rare indication for us as a transplant in the pediatric in Saudi Arabia because of the cut limit until the age of 14 of treatment. But again, there are three things that we have to put in mind in APL patients who relapses: time of relapse, prior ATO therapy, and failure to clear the PCR of the PML-RARA. The question of allo versus auto has always been discussed, and that's why a big group of APL specialists around the world have met and set to do a data, an algorithm guidelines headed by Dr. Abla and the group. And you could see different algorithms. You could always refer to it with this reference. But it is important to mention that nowadays we use ATO as a standard of care. So probably the arm of no previous ATO will go away. Then you will go just, if you are early relapse before 18 months, and then you have previous ATO exposure, which is most likely, then you put these patients on remission by chemotherapy and go for autologous transplantation if you are PCR negative, or if you are PCR positive, you go for allogenic transplantation. Now, I put in red down here because one of the comments, if you have match-related donor, you could go also for allotransplant and those early APL relapses, which we do actually in our society. Now, on the other hand, if it's a late relapse, then the decision will be, if a previous ATO, then you just go ahead with the, put the patient in remission, go for auto transplant if you are PCR negative, go for allo transplant if you are PCR positive after 4 cycles of APL therapy. So this is the summary. No transplant if you are ATO naive or you are very late, plus clearing the PCR. Auto if you are ATO naive or children with prior ATO and still had positive, clear the PML-RARA at the end of 4 salvage therapy. And you do allo if you have primary refractory or the rest of the group. So just finally, I'll go just very quickly on our data and cash for patients with leukemia. So we only transplant around 23% of those 500 are, like let's say 350 patients, 400 is including the auto. 23% are leukemias. You see most of our transplant are hemoglobinopathies and bone marrow failure syndromes and primary immune deficiency. Collected the data recently. 71 patients have been transplanted, leukemia patients. 43 are ALLs, 28 are AMLs. For the ALL, 43 patients, as expected, the majority are CR2. There are the demographic of match-related haplotransplant, match-unrelated, and cord. And for AMLs, 18 are CR1 and 10 is CR2. And this is a bias here. If you look 18 in a CR1, because we are including the intermediate risk group who have match-related donor. Okay? So looking at outcome Of the ALL, around 79%. The events around 30%. Out of those 13 who had events, 11 relapses and 2 TRMs. If you look out of those 43 patients, 10 of them were haploidentical, 5 of them are alive, 3 relapsed, and 2 had TRMs. If you look at the AML group, around 28 patients, the outcome is much, much better, you know, but part of it because we included the intermediate risk here because of match donor availability in the absence of MRD assessment. In the haploidentical setting, also they did or mismatched donor, 8 patients, 7 alive, 1 TRM, and the TRM is like a chronic GVHD after 1 or 2 years post-BMT. This is the general outcome of this center. And finally, with the take-home messages, you know, always rethink about the indications of transplant because it's very crucial and it's changing in the presence of current therapies and CAR-T. Prepare your patients. TBI-based regimen is the standard of care in ALL, and busulfan-based is the standard in AML. And with that, I would thank everybody.
Thank you so much, Dr. Muhammad, for this really informative lecture. The last lecture in our session is with Prof. Stephen Hanger from Children's Hospital of Philadelphia. We'll talk about CAR-T cell therapy in children.
Okay, I will start in 3, 2, 1. Thank you very much. I will now speak on chimeric antigen receptor, or CAR T cell therapy for pediatric ALL. And again, I wish I could have attended in person. That was not possible for me this year. Hopefully I will be able to attend next year in person. My disclosures are as listed here. Now, I spoke earlier about outcomes for newly diagnosed ALL, but however, when we start to look at relapsed ALL, we see that the outcome for second or greater relapse is particularly poor. So the complete remission rates are lower with each relapse or new treatment attempt. So at first relapse, 85% of patients will enter a complete remission, second relapse, 44%, third relapse, 27%. And the disease-free survival rates become progressively lower with each relapse. Second complete remission, 27% at 5 years, third or greater, 15% at 5 years, and the survival rate for patients that relapse after a prior allogeneic transplant is generally less than 10%. Now, this has been changed with the development of CD19 redirected CAR T cell therapy. So just as a quick summary, CAR T cells, the T cells are genetically modified with an engineered T cell receptor, or TCR, that contains a single chain variable fragment that recognizes a particular epitope, in this case CD19, which is expressed in almost all malignant and normal B cells. The T cell receptor includes the CD3 zeta activation domain and a co-stimulatory domain that enables T cell proliferation and expansion in vivo. The co-stimulatory domain in the University of Pennsylvania and Children's Hospital of Philadelphia, or CHOP CAR T cell products, and the FDA-approved tisagenlecleucel, or Kymriah, is 41BB, or CD137. This particular co-stimulatory domain is associated with increased persistence of CAR T cells, which we believe is very important to treatment success. And this depicts how CAR T cells are made. First, A patient is leukapheresed to collect T cells. The T cells are isolated ex vivo and then are transduced with in this case, a lentiviral vector to express the chimeric antigen receptor. They undergo expansion ex vivo, and eventually the product is completed. In this process, this takes about 3 weeks. The product can then be shipped live for direct use or can be frozen for future use. Patients then receive chemotherapy, so-called lymphodepleting or LD chemotherapy, and then receive a CAR T-cell infusion. So these are the patient's own these are genetically modified T cells from the patient himself or herself. An important thing to remember, which I'm not going to go into in detail, is if the patient has never had a transplant, these are the patient's own autologous T cells that are transduced. However, if a patient has had an allogeneic transplant, generally the T cells you collect after allogeneic transplant are derived from the donor, so they are allogeneic CAR T cells. Now, proliferation is critical for effective CAR T cell therapy, and this, I think, is a very important concept. The number of cells you infuse is relatively modest. So if you look, this is the gate where the CAR T cells are. So looking a day after infusion, you don't see any CAR T cells. All the T cells are normal T cells. However, when you look 2 weeks later, you see that 70% of the circulating T cells are CAR T cells, very similar at day 21. So I think one of the most important things to understand is that this proliferation has to occur for the CAR T cells to be effective. Now, these CAR T cells can persist for long term, and we can continue to detect CAR T cells both molecularly and functionally by the resulting B-cell aplasia more than 10 years after initial infusion. So CAR T cells can be long-lived. They are not always, but they can be. So in terms of developing CD19 CAR T cell therapy for relapsed and refractory ALL, my colleagues at the Children's Hospital of Philadelphia and the University of Pennsylvania were leaders. The first report by Stephen Grupp, who leads our CAR T cell program in 2013, described responses. A year later, the group reported again, led by Shannon Maud and Steve Grupp, and showed that these responses were durable in the short term and consistent among patients. However, these were single institution studies with the CAR T cells manufactured on-site at the University of Pennsylvania. It was very important to show whether or not that could be generalized. And indeed, this was, and published in 2018, was the study that led to FDA approval of tisagen lechlusel. And I'm going to go through that in the next few slides. So this trial was named Eliana. It was the pivotal phase 2 trial and was the first global multi-center trial of CAR T cells. So the drug, tisagen lechlusel, or CTL-019, was produced at a central manufacturing facility, initially one in the United States in New Jersey, but then expanded to one in Europe and eventually to one in Asia. 25 sites across 11 countries in North America, Europe, and Asia Pacific participated. So the T cells were collected from the patient at the site, shipped to the manufacturing facility, and then the CAR T cells were shipped back about 4 weeks later for infusion following lymphodepleting chemotherapy. The eligible patients had relapsed and refractory ALL, and they were very heavily pretreated. So there was a median of 3 prior therapies with a range of 1 to 8. The median marrow blasts at the time of enrollment was 74%, and 61% of patients had previously undergone allogeneic transplantation. And this is the initial report in 2018 in New England Journal of Medicine, led by Shannon Maud and Stephen Grupp from our center. And it showed remarkable responses. So 82% of patients attained a complete remission within 3 months, and 98% of the responders were minimal residual disease or MRD negative at the time of response assessment using flow cytometry. And among the responders, the relapse-free survival was 62% at 2 years, and the overall survival was 66%. So extremely encouraging results in these heavily pretreated patients, and these results led to FDA approval of this product. Now, it's always important to ask, is this a generalizable result? Sometimes patients who enroll in clinical trials are often heavily pre-selected, and many times when you go to use a drug in the real world, you don't see results as good as you did in the clinical trial. Well, this is not the case with tisagenlecleucel. I think this is a very important study that compared the outcome of 250 patients reported to the CIBMTR and their response to tisagenlecleucel or Kymriah compared to that seen in the Eliana pivotal trial. And here we see almost identical responses, 85% versus 82% complete remission, MRD negative, 99 and 98%. Duration of response at 12 months, 60 and 67%. Event-free survival at 12 months, 52 and 57. Overall survival at 12 months, 77 and 77%. So this is a very important trial that tells us, or report, that tells us that when you move into the real world, the outcome is just as good as seen in the initial trial. And Susanna Rivas has recently updated the reports of the Eliana study at the EHA meeting earlier this year. And here we see 5-year event-free survival if you don't censor for the patients who underwent allogeneic transplant was about 44%. If you censor for allogeneic transplant, about 34%. 5-year overall survival was 55%. So what does that tell us? Well, what I think it tells us is that CAR T-cell therapy is curative for some patients with highly refractory ALL. However, it doesn't tell us who these patients are and how we might identify them prospectively, which I think is the most important question in the field currently. And I'm going to talk a little bit about outcome from our center at the Children's Hospital of Philadelphia. We have now treated more than 450 patients since 2012. This program is led by my colleague, Stephen Grupp. And this slide just shows you over time the rate of patients who have been hospitalized after CAR T-cell therapy is now about 50% in the most recent time. So about 50% are treated completely as outpatients. And intensive care admission was common early on, and now we're down in the range of 10% of patients end up in the intensive care unit. And there are two reasons for these improvements. First, obviously, we've gained more experience over time and know how to treat patients better. Second is we have started to move into patients with lower disease burdens or less likely to develop cytokine release syndrome, which I'm not talking about in detail today. So should CAR T cells be a bridge to hematopoietic stem cell transplant, or should they be a definitive therapy? Most likely the answer is both, but how do you pick when to do one and when to the other? If you look at the early CAR T cell trials, somewhere around 65 to 75% of patients had relapsed post-transplant. Many patients then entered complete remission and did not receive subsequent therapy. And we clearly see a long-term plateau in survival, showing that CAR T cells can be a curative therapy, but we lack guidelines as to who needs transplant post-CAR and who might be cured without further therapy. And there is substantial institutional variation. The approach at our center is generally to use CAR T cells as planned definitive therapy if response benchmarks are met and maintained. Other centers use CAR primarily as a bridge to transplant. And I am not saying one is right and the other is wrong. I'm just giving our experience, because my question as someone who's treated leukemia my whole career is who can we use this therapy to avoid transplant? So the desired response following CAR T-cell therapy is we want to see an MRD negative bone marrow via flow cytometry by day 28 post-infusion, and we want to see this sustained. This I'll talk about in a few slides. Next generation sequencing or high throughput sequencing minimal residual disease is more sensitive and may become the response endpoint of choice. We also look at B cell depletion. This is a surrogate marker of activity. And so the goal is no detectable bone marrow or peripheral blood CD19 positive cells for at least 6 months. Might it be 12 months? I don't know. And patients, as I've mentioned, can continue with B cell depletion up to 10 years post-infusion. Although I'm not going to go into it, if this happens, it leads to long-term immunoglobulin replacement therapy. And at our center, we typically intervene if these benchmarks are not met or the response is lost. So what impacts the efficacy of CAR T cell therapy? Well, clearly disease burden does, and we are now learning this. So this first slide looks at event-free survival. This is from a CHOP study of early use of tocilizumab, which I'm not going to go into, but here, what our practice is to perform a bone marrow after completion of lymphodepleting chemotherapy. So this is immediately prior to CAR T cell infusion. And here you see that patients with high tumor burden, defined here as more than 40% bone marrow blast at that time, have a significantly worse outcome than those with low tumor burden. This is not necessarily surprising, but it is quite clear. This is another study. This is a report of 420 children treated with CAR T cells for relapsed refractory ALL at 7 centers from 2012 to 19, reported by Regina Myers from our center. And patients with circulating blasts on the day of CAR T cell infusion had a significantly worse outcome than patients without circulating blasts at this time. So I think we know that the disease burden at the time you enter CAR T cell therapy impacts outcome, and this may be one of the things we should consider in deciding whether or not to proceed to transplant post-CAR. Now this is a study of humanized CD19 CAR reported by Regina Myers and Shannon Maud from our center. And this is an early report and the results were quite encouraging. But what I want to highlight is that B cell recovery is associated with an increased risk of relapse. So here we see in blue, the patients who have B cell recovery have an inferior relapse-free survival to those without B cell recovery. And again, B cell recovery is a surrogate for activity of CAR T cells, because if the CAR T cells are killing CD19 positive cells, then you should have no normal circulating CD19 positive cells. Now, I mentioned minimal residual disease. This is a paper published earlier this year in Cancer Discovery, and they assessed minimal residual disease and B cell recovery in 143 patients after tisagen-lecleucel treatment. Now, several important observations from this study. First, 80% of relapses occurred within the first year of infusion, so getting to 12 months in remission is a very important endpoint. B cell recovery typically occurs within 6 months, and late B cell recovery may not be predictive of outcome. So 5 of 6 patients with B cell recovery greater than 12 months post-therapy continued in remission. Next generation sequencing MRD at any level, so a value greater than 0, was highly associated with relapse. And on multivariate analysis, the most important thing was the NGS MRD. Now at 3 months, clearly patients who were MRD positive at that time had an inferior outcome, but some patients with MRD greater than 0 cleared that MRD and were long-term survivors. However, at 3 months, detectable MRD greater than 0 was highly associated with outcome, and 41 of 42 patients who had this MRD at that point or later either relapsed or received other therapy. And finally, relapses that occur with ongoing B-cell aplasia are largely CD19 negative. Now, this just shows the data from that paper. And on the top, we're looking at event-free and overall survival based on MRD at 30 days. And here we do see a big difference between the curves, but some patients who are MRD positive do well long-term. So our feeling that this is too early to act on. But if you look at the patient's MRD greater than 0 at 3 months, we see a dramatic difference in outcome. So somewhere between 1/3 and 1/2 of patients do not relapse post-CAR. Who are they? What are the pre-infusion characteristics? Well, disease burden pre-CAR is the most useful clinical factor, but we need measures of CAR T cell fitness and potency. Can we predict a priori who will have long-term persistence and activity of CAR T cells? And then post-infusion characteristics, the MRD burden post-infusion is highly predictive of outcome. Next generation sequencing is beginning to replace flow cytometry. I'm not sure we're there yet, but we're getting close. Our practice is not to act on day 28 NGS MRD that is detectable, but flow negative. But we do repeat it in 2 to 4 weeks and are concerned by that. B cell recovery, the timing of recovery is important. We intervene if B cell recovery occurs within 3 to 6 months, not if it takes longer. 3 months may be the critical point, but I think it's a little too early to know for certain yet. So this is just an example of a patient. I saw this patient in our clinic several weeks ago. He was diagnosed with KMT2A rearranged infant ALL at 4 months of age, treated on a Children's Oncology Group study with an experimental agent, had an isolated bone marrow relapse during maintenance about 15 months after diagnosis, and underwent a cord blood transplant with total body irradiation prep at 22 months, and then had a bone marrow and testicular relapse at 18 months post-transplant. I've been taking care of leukemia patients for a long time. If you had asked me at that time, which was in 2015 or 2016, I would have said this patient was likely incurable. And I'm very happy to say that I would have been wrong. He was treated with chemotherapy and testicular radiation. 6 months later, was treated on our trial of humanized CD19 CAR therapy. He received 2 reinfusions for early B cell recovery, the first with an additional course of lymphodepleting chemotherapy and the second without it. When I saw him several weeks ago, he was 6.5 years following his first CAR infusion, 6 years after the third infusion, has received no subsequent therapy, continues in remission and doing very well in the 4th grade, with his main problem being that he's quite short. So what predicts cure after CAR therapy? How do we predict who can be cured and should, as I like to say, ride the CAR, and who should undergo bone marrow transplant post-CAR? One of our young faculty is trying to address that question now. She's assembled a cohort of approximately 50 patients treated at CHOP with CAR T-cell therapy who remain in complete remission 5 to 10.5 years after CAR T-cell therapy with no subsequent treatment. She will analyze the pheresis product, the infused CAR T-cells, and peripheral blood samples early post-CAR and 5+ years post-CAR in an attempt to address this question. Hopefully we'll have some answers in the coming years. So I want to thank all the members of our cellular immunotherapy program at CHOP, led by Stephen Grupp. We showed you data from Shannon Maud and Regina Myers in particular, and the overall program at the University of Pennsylvania is led by Carl June. Thank you very much for your attention.
Thank you so much, Prof. Steve. Now we'll open the theater for question. I think not more than 10 minutes because there is a bus also for, we'll go for Friday prayer.
Maybe I can ask one question to Dr. Al-Isa. You just touched based on the use of MRD post AML. So do you think measuring MRD post bone marrow transplantation in ALL with chimerism will prevent the relapse? And if yes, what are the options of using BLINA post-BMT based on MRD?
Yeah, excellent question with no clear answer, of course, because yeah, MRD assessment post-BMT is something that we do routinely in our hospital, but certainly the science and the literature is very variable in managing those positive MRD in the current era compared to previously. Previously, the first step is the tapering immunosuppression and giving DLI, especially in the presence of mixed chimerism. We advocate for DLI in that case. Now, the use of BLINA is under study, and especially with the current thing in ALL and the presence of CAR-T as an option, we might argue that the current era is different. However, the BLINA study, I mean, there are multiple studies ongoing, but I know one of them is already stopped for toxicity post-BMT. But I cannot generalize, but it's a clinical trial that was stopped because of severe adverse reaction from BLINA post-BMT. But it is an option to do that. The problem with BLINA, theoretically, post-BMT, that the immune reconstitution and the T cell number will not be as good as pre-BMT. So how would a BLINA work post-BMT unless the patient has, enough T cells? But again, people are trying it, and there is conflicting outcome, and some of them are using it.
Any other questions?
Yeah, maybe one question to Dr. Isa and Dr. Shahrani as well. Would you consider a patient with persistent MRD positivity with an ALL, persistent MRD positivity after consolidation, that was cleared after that with blinatumomab or other treatment? Would you consider this patient for CAR-T, and do you think the outcome would be better than going for transplant?
So BLINA, and a patient becomes negative, I will go for transplant as a standard of care. The argument would be that there's no data about CAR-T in that situation, because for the CAR-T to work, it needs some burden of disease and for T cell proliferation. In addition, I'll be worried about the BLINA outcome and the CAR-T post-BLINA as an inferior outcome with CD19 negative relapse. These are my thinking process right now. I'm just going through it. But I would just go for BMT, and I would not go for CAR-T. The problem with CAR-T in the future and the coming is the current clinical trials, because there are listed commercial, like indications by commercial versus the in-house manufacturing of the CAR-T. And that will put a burden on the future. The problem that Dr. Steve was mentioning currently, what are the clear indications of CAR-T, and how can we avoid transplant completely? This is what Dr. Shahrani.
Well, there is no comment. You and Dr. Ali, they are the CAR-T still man. But as you say, we will go with the standard. For time being, we'll go with the standard care. Yeah. But I don't know, maybe Dr. Ali, can you just comment about? Yeah.
I didn't hear the question, so if you can repeat.
Yeah, so it's a patient who had very high MRD after induction, high risk ALL, B-ALL, very high MRD after induction, continued to have high MRD after consolidation, and even post methotrexate, only cleared MRD with blinatumomab. So it was a high MRD, very high, like 3-5%. You can call it M2 after induction, then persisted positive after consolidation, and then even after methotrexate, and only cleared with blinatumomab. So do you think we should still go for the standard as BMT, or you think CAR-T can offer extra advantage in cure, and would this be applicable with the current evidence?
Maybe I didn't hear the whole question because there is a lot of echo. But you mean post-transplant?
No,
Before.
no. This patient is now in CR1.
So using Blina before stem cell transplantation?
Blina was used only to clear the MRD.
Well, if I understood the question very well, I mean, if, for example, if there is significant MRD persistent, the option really is whether really is this patient likely to go for CAR T cell, then probably to save this patient from using Blina and use other salvage chemotherapy, because that Blina probably will deplete B cells, then this patient will not be candidate for CAR T cell. If you think that MRD is not that significant and likely to be controlled by Blina and will be MRD negative and likely to go for stem cell transplantation, then the options really is to go for stem cell transplantation. If in Blina post MRD or persistent disease post Blina that who underwent CAR T cell, the outcome is really inferior than those who was not exposed to Blina.
Yeah, thank you. So let's take the blinatumomab factor away. So let's look at this patient after interim maintenance 1 who continued to have a positive MRD. At that time, would you think of, okay, I'm going to give him something like anituzumab or another chemotherapy to put him in a better remission and take him for CAR T, or to use blinatumomab and go for BMT? Actually, Blina was given for the intention of preparing him for BMT. But I'm just trying to go backwards one step and see.
The issue of using ENO prior BMT is there is the high risk for VOD. That's the only issue. But I think such patient is just to the only concern putting those patients in MRD negative before BMT. So if you manage by using Blina or ENO to put them in remission before BMT, then I think the way is to go for BMT.
Yeah, this is the same answer that we were talking about before, but I agree.
So it's good you didn't hear the question, so it was blinded. Yeah, so it was a blinded answer. Yeah.
So we had the same answer, the same opinion. No, just one thing, but I really, I like the idea of, so what percentage of end of consolidation, let's say, or end of, let's say, intermittence, whatever, number of blasts that would tell you, do not try Blina, just go ahead with CAR T. This is the question that is not very clearly understood. We know by experience, probably, the higher the burden, the Blina, less likely to work. Some people give 5% as a cut limit, some people give different ranges. But let's say if you have above 5%, I probably would consider, I know, or CAR T directly if it's valuable. But this is something that, if you give Blina, and this patient could go into remission, then I'll go for BMT. So it comes to also cost, availability, and many other factors.
Our approach for such patient with significant disease burden is to avoid, as Dr. Muhammad mentioned, the use of Blina, because Blina likely not to work for those with high disease burden, and control the disease with, if it is high, with flag, and later on, and then to go for stem cell transplant, for CAR T cell therapy. But if at a level of MRD, then I think Blina and stem cell transplantation. طيب, I have a question for Dr. Muhammad, since he will, you want to go? Okay.
I have simple question. Okay. When the CAR T invented for the first time, they talked about using, or principle of using CAR T to put a patient in remission with MRD positive. Is that still valid?
Actually, people think that CAR T is an easy procedure. I remember that one patient referred from Dr. Ballura, I think Down syndrome with ALL, or Dr. Manjumi, and she came to the clinic that I want to do CAR T, and it was actually the not indicated at that time because she was on the reinduction. I told her can be fatal procedure, but she insisted. Later on, after evaluation, bone marrow evaluation, after reinduction, confirmed that there is a disease persistent and become refractory. Then she was transferred to us. We started, we infused her with CAR T, and he developed severe CRS and ICANS. Even the ICANS did not respond to dexamethasone maximum dose. So to the degree that I started pulse steroid, methyl 30 milligram per kg. So about to die really. I saw her in the clinic. Alhamdulillah, he was okay, discharged. And I reminded her that when she insisting at that time to go for CAR T. So it's a still procedure really that there is a high chance of mortality really. It can be very fatal. I mean, ICANS can go to coma and infections and etc. So I think there are certain indications for CAR T cell which has to be disease refractory, induction failure, or 2 relapses or more, or post BMT, or Down syndrome, of course, because they cannot tolerate conditioning and go for BMT. So I think this is certain indications rather than use CAR T for putting the patient in remission.
Dr. Muhammad, only last question. We saw from your data that outcome in AML, it's better from ALL in your hospital. It depends on the number of cases, or you have
No,
any
so
comment?
two things. I agree with you, but let's look at the ALL. The ALL is matching with the international, which is like around the 70% range, etc. So this is very good for ALL. If you break it down to CR2 and CR1, it's acceptable. If you go to haplotransplant, it's 50%, which is also acceptable for haplo-ALL internationally with the current data. For the AML, the bias is we are doing more intermediate risk transplant because in the unavailability or like validated MRD at a very long time, we were taking those patients to transplant with intermediate risk in the presence of match-related donor, which is a big possibility in our situation. And that may have biased the outcome because you look at the data, you see CR1 is 18 patients and CR2 is 10 patients. So this biased the group totally. I think this is the interpretation that I could get.
It's just really a question about CAR T. I mean, the safest CAR T now, which is the second generation that we are using. But of course, there is a third generation that 2 co-domain there, but it was very toxic at the research level. But now, and from Chinese experience, and they confirmed that upfront use of steroid, that will not really affect the function or persistence of CAR T cell. I was discussing with Dr. Kharfan yesterday. In Mayo Clinic, they started to use upfront dexamethasone for certain group patients of lymphoma without affecting the CAR T cell persistence. My question is, I thought, is it the time now to move for third generation CAR T cell using upfront steroid to mitigate the risk of CAR T cell toxicity?
Yeah, so clearly this is just, we're just recruiting patients with CAR T now in our center, but the data is intriguing that at the beginning, by mechanism of action, that the steroids affect and the TOSI effect, whether it affect the outcome of the cells. And now people are more liberal with tocilizumab use earlier during toxicity, and we are hearing about use the prophylaxis, yes or no, tocilizumab as part of the treatment of avoiding toxicity. Now, for the steroids, I'm worried. I really don't know the data on the long term, and even in the current data. In adults, it might be different because their CRS with lymphoma is very extensive with the current product, the Axicel, that is CD28, and they usually have intense more CRS and more neurotoxicity per literature and per discussion with my colleagues in adult. Steroids might be something that we will know in the future. I really don't know, and I have a clear answer for that.
Thank you so much. I think we came to the end of this session. I will leave the mic for Dr. Amin.
Thank you, Dr. Ali. Thank you for all speakers. Now we'll invite the speaker for recognition. Dr. Muhammad Isa, Dr. Ali Al-Ahmari. There is buses for, we'll go to the mosque for Friday prayer. It's here in the, I think, in the Nakhil door, not in the lobby. It's here. Yeah. Okay. Lunch will start at 12 p.m. also, after prayer. And the next session will start at 1 p.m. الله يعطيك العافية. خلينا نسرق المحاضرات. خلينا ناخذ محاضرات. كنترول باست. لا هذه تمام. ما عم تفتح ليش؟ ليش بس وحدة راحت؟ اي عادي. سعيدة.
17p deletion and produces similar result. However, the statistics were not that different when looking at standard risk receiving double versus single. And thus maybe double transplant remains a really good option for those with high risk cytogenetics. So what about maintenance therapy? Are we moving beyond the single agent lenalidomide, adding these alternative agents, ixazomib, daratumumab, or adding agents to lenalidomide like proteasome inhibitors and the anti-CD38? So in this meta-analysis of three phase 3 trials, they looked at lenalidomide versus observation. Clearly, lenalidomide improved PFS and overall survival, and it was quite significant statistically at 7 years follow-up. Emory had a study where they used RVD as a maintenance therapy with patients in high-risk myeloma, and it's been increasingly used in such a manner with a reduced dose of lenalidomide. And this cohort of patients, although not that many, 45, it produced a good PFS of 32 months and with a median follow-up of 26 months with a 3-year overall survival of 93%. So the tourmaline MM3 PFS maintenance with ixazomib, it produced somewhat a good PFS with 26 months compared to placebo 21. It was towards statistical significance. That was even more true for those achieving MRD negativity. But it wasn't that, compared to LEN, it wasn't that significant. So this is the Cassiopeia, again, going back to it for the second randomization where they looked at maintenance data versus observation alone, which is interesting. They had the control with no LEN maintenance at the or any kind of maintenance really. What data was received here every 8 weeks. The PFS, as might expected, showed a superiority of daratumumab maintenance versus observation, and that improved the hazard ratio as well, statistically significant. Going back to the Griffin, the second maintenance and looking at the updated PFS, where after almost 50 months, the PFS rate in 4 years is 87 months for the DARA arm versus 70% for the LEN arm. So it's a longer PFS for sure, and median PFS not reached for both. And the Forte, the one we've mentioned again, at the second randomization looking at KR versus R maintenance, the 3-year PFS showed superiority for the arm that included carfilzomib, 75% versus 65%, again, statistically significant. So what about the transplant ineligible? Of course, we already know they're frail, they have multiple other issues and comorbidities. So in this phase 3 first trial, survival with RD continuous showed superiority versus either 18 months RD or melphalan, prednisone, thalidomide, with a 4-year PFS of 32% versus around 14% for the other two arms. However, the overall survival was not that significantly different, but both RDs were better statistically compared to the MPT. In the SWOG trial, they looked, it's a phase 3 trial and randomized, RVD versus RD, previously untreated myeloma patient in the frail. The 5-year overall survival was much better at the RVD, and the median was not reached compared to 69 months for the RD arm. What's that? And now the VRD Lite, a regimen I have used a couple of times as well in an older or transplant ineligible patient. In this study, an overall response of 86% of patients, and many of them achieving VGPR with a PFS of around 35 months. And came in the Maya trial, increasingly being used in our population of patients in the transplant ineligible, where the control arm received RD, and then the other experimental arm received DARA RD, and that was a 28-day cycle until progression. The primary endpoint was PFS, and at 30 months, DARA RD was significantly better with 71% versus 56% for RD, and an overall response as well, 93% versus 81% favoring DARA, but the most important is the MRD negativity of around 24% favoring the DARA arm versus 7% only for lenalidomide. So this is the updated analysis, looking at DARA-RD at 48 months. Again, the separation of curves is widening, and it's now 60% for DARA arm versus only 38% for the RD arm. And the overall survival was trending toward statistical also significance. The tourmaline is the IRD versus RD, and it did produce somewhat not such bad results, but I wouldn't go too much into it. So treatment consideration in special populations, we always need to look at the frail elderly and use the correct regimen for them. The renal dysfunction patients, looking at maybe VRD adjusted LIN or VCD, which is still actually being used in King Faisal as the main induction regimen till this day. So they're not using VRD, they're still using VCD. Maybe Doctor, you know about that as well. In cardiac dysfunction to avoid carfilzomib, peripheral neuropathy, maybe looking at bortezomib sub-Q, which I think now everybody is using subcut bortezomib, or consider induction with carfilzomib or ixazomib. Aggressive high-risk disease, use KRD, DARA-VRD, which we have been now tending to use DARA-VRD in our high-risk patients. Extramedullary disease, we are using VCD, VRD pays increasingly in those patients, especially if multiple. Of course, I could not go into all of the things in the initial consideration, but never forget, these are all topic on their own: VTE prophylaxis, the vaccination for myeloma patients, and post-transplant, infection prophylaxis, pain control, cord compression, a very important part in myeloma treatment when they present as an emergency, management of bone disease, looking at the biphosphonate, the denosumab, and looking at kyphoplasty, vertebroplasty, diagnostic imaging in myeloma, and the choice of those, looking at PET versus MRI versus the low-dose CT, neuropathy control, anemia, hypercalcemia, and acute kidney injury control as well. Thank you, and with that, I conclude my talk.
Thank you, Dr. Omar. You are on time. Second speaker.
Our next speaker, Dr. Muhammad Kharfan Dabaja. He is a hematologist and a medical oncologist. He's a professor of medicine, vice chair, hematology director, blood and marrow transplantation and cellular therapies director, inpatient hematology unit medical director, cancer research office, Mayo Clinic, Florida campus. He will speak about relapsed refractory multiple myeloma updates.
Thank you, Dr. Antar. Assalamu alaikum wa rahmatullahi wa barakatuh. It's indeed an honor to be with you today. I want to also thank the leadership of the Al Musa Specialist Hospital for extending this invitation, and Dr. Antar for this wonderful organization of this meeting. So Dr. Abdul made my life easier for the first few slides, because really I wanted to emphasize the role of autologous transplantation in CLL, in multiple myeloma. And I would say that to this date, there is not a single study I am aware of that has shown superiority over autologous transplant. So autologous transplant should be the way to go as a consolidation in frontline, obviously for transplant eligible patients. I'm going to share with you some of the background of CAR T-cell therapy and what led to the approval of these CAR T products, particularly ide-cel and cilta-cel. And also I'm going to touch on bispecific that was just approved less than 10 days ago, teclistamab in the United States. I'm going to also try to share some of the important data on belantamab with understanding of the toxicity of this product that has made it a little bit difficult to use, and finally take some messages home after this presentation. So high-dose therapy and autologous transplant in multiple myeloma, and this is recently published last year by Dimopoulos and colleagues from it's a joint effort by EHA and ESMO, and this is the way myeloma treatment landscape continues to be. Patient is eligible for transplant. If yes, then these are the choices for induction that were elegantly described in the previous presentation. And patients obviously should be considered for selected cases. You can adjust the dose of melphalan to 140. At our center, we tend to use that dose when patients are older than 70 years of age or those who have serious comorbidities. I would say lenalidomide maintenance versus Velcade maintenance, both are acceptable options. There is some data suggesting that lenalidomide, perhaps in a CIBMTR series, is better. But in our center, we are biased when we have bad mutations to use Velcade instead of lenalidomide. And this is the data that led to the role of autologous transplant in myeloma, obviously going back to almost 30 years ago, showing for the first time that high-dose therapy was superior to conventional dose therapy. So the argument of the non-transplant or the non-believers of transplant is that, well, this is data from the many years ago, and now with new therapies. And again, in this particular study by IFM, it showed that superior, not only event-free, but also overall survival. This is the most recent study, and different from the IFM study, this study really did not put a limit on the maintenance duration of lenalidomide. So these patients received maintenance as long as they could take the maintenance, or if they have no signs of progression. And you can see here for the group that got the auto transplant, median PFS of 67 months versus only 46 months for the RVD alone. At 5-year survival, there was no statistically significant difference, with the hazard ratio being 1.1. So auto transplant in myeloma is the way to consolidate patients. Now, your choice of 3-drug versus 4-drug, I think you have to really keep an eye on the patient that is in front of you. And this data shows that delaying transplant, this is from the Mayo Clinic in our campus in Minnesota. You can see on the blue curve, that's the control. These are patients taken to transplant in frontline consolidation. And the red curve is the group of patients that were taken to transplant later on. You can see a median survival of 112 months versus only 80 months. So significantly different. This is retrospective analysis, obviously. But what is important is that delaying transplant not only results in inferior survival, but 11% of the patients who you plan to do it never get a transplant done because of many reasons at that time. So this is certainly the landscape of how myeloma looked before the year 2000 and what it looks nowadays. And you can see the addition of therapies. I would say probably thalidomide is questionable to be targeted, in my opinion. But certainly more recently, we can see teclistamab with being a bispecific. Also, ciltacabtagene autoleucel, cabtagene vicleucel. So we're really looking into personalizing the care of these patients with certainly very effective therapies. So what is the best treatment for second line? These are patients who have failed frontline therapy. And I simply would follow this algorithm by Dimopoulos, where you really look into the patient of, are they lenalidomide sensitive or are they lenalidomide refractory? Are they bortezomib sensitive or are they both refractory to lenalidomide and bortezomib? And then you have all the options here. Many of these actually have not been compared head to head, so it all depends on the comorbidities, what type of patients comorbidities they have, and what type of therapy you think they will be used. I would say in our center, we rarely use elotuzumab. We don't feel like it's as promising of a therapy as daratumumab. And I would say that probably in the last 5 years, I may have prescribed that drug once or twice. So not a big fan of elotuzumab. Patients who fail 2 or more lines of therapy, specifically when we start getting into the triple refractory or penta-refractory, this is where CAR T-cell therapy appears to be playing a role in these patients. So what is a CAR T-cell therapy and what is a normal T-cell? So normally, you have a T-cell and you have a tumor, and they tend to interact through T-cell receptors that you can see on the figure A. And usually they use the major Higgs compatibility complex through beta-2 microglobulin to actually identify and be able to eliminate that cell. So CAR T-cell, it has more benefits than a regular T-cell in that it can localize the tumor better, it can be more killing, cytotoxic activity, it expands better, and it can persist for a longer time. And this is the marvelous of T-cell engineering, where you have a signaling domain for these products to typically be a 4-1BB or CD28. And then you have antigen recognition domain, which is really the CAR component on that figure E. And then you have your target antigen on the tumor cell. Now for lymphoma, I'm going to be speaking later, all the products are CD19 specific. For myeloma, we look at this BCMA, or B-cell maturation agent, which is really the target for which the 2 products are currently approved. So this is the way we manufacture the CAR T cells. These cells are collected through a process of leukapheresis, typically around 4.5 to 5 hours. These cells are shipped to a lab, typically takes 24 hours for them to arrive in the lab. Automatically they start processing the cells, so typically there will be a process of transfection. So they will insert the CAR T into the T cell using typically a lentivirus most of the time, or a retrovirus if the product is Yescarta or Axicapta cellulosa, which is a lymphoma product. But most of them are using lentivirus instead. The CAR T is manufactured, grown and expanded in millions. They have to undergo a quality control. And then these cells, typically, we will get notification a few days earlier that the cells should be arriving on a specific day. We will infuse the patient after giving the lymphodepleting chemotherapy, typically fludarabine, cyclophosphamide, and then usually we follow them with the infusion of CAR T cells. And this is supposedly the way it works. Those CAR T receptors will identify the cancer cell and eliminate that particular cancer cell. So this is the B-cell maturation antigen. It's one of the most important, in my opinion, targets in myeloma. It's a member of the tumor necrosis factor superfamily, and they typically express on mature B lymphocytes and not expressed on hematopoietic, on the stem cells or cells of non-hematopoietic origin. Now, BCMA is essential for the long life of plasma cells, so it's certainly an important in the process of B-cell growth and survival, and in the persistence of those plasma cells. And overexpression is associated with progression of multiple myeloma, and I would say that this is probably one of the best targets that exists so far. Another target that seems to be gaining some interest is CS1, but we don't have a commercial approved CAR T cell for that yet. So these are the two products. The first one is Abecma. This product came first into the market, and it's an autologous CAR T cell, uses 4-1BB signaling, and it only targets one binding, or it has only one binding domain for BCMA, different from what we see with the right one, which is ciltacabtagene autoleucel, non-commercial as Carvykti. The difference is that it has two BCMA target sites. In my opinion, it's a superior product. So if a patient requires CAR T cell therapy and I have the choice, and I'm going to share with you some of the limitations of why I don't have the choice all the time, I would perhaps biasly choose Carvykti over Abecma. So Abecma was approved based on this KARMA trial, and this study was a multi-center study conducted mainly in United States and Europe. And this study enrolled patients median age somewhere between 54 to 62 years of age. So the first thing that comes to mind, if you remember the presentation of Dr. Abdjalil, is that the median age of myeloma tends to be somewhere between 65 to 72 nowadays, or 73. So certainly there is selection bias. We are not really offering this product to all patients. We are selecting some of these patients. Now, in real world, we don't have that restriction as we have in clinical trials. We have offered CAR T cell therapy to patients above age of 80 these days. In terms of cytogenetics, you can see that a quarter of these patients have had high-risk mutations, whether 17p deletion, translocation 414, or the 1416 translocation, or others like the 1q augmentation or amplification. So there were 3 doses that were evaluated in this. Once we got the cells leukapheresis manufactured, the patient got fludarabine and cyclophosphamide, typically on a -5, -4, and -3 dose schedule. And then we have the first assessment of response at 1 month. When we look at the dose of the Abecma, it seemed that there was superiority in terms of responses using the 300 million or the 450 million cells compared to the 150 million. And this is really where the doses that are currently approved for that. Overall, of the patients that were treated, overall response rate 73%, with a complete remission rate of around 33%. So impressive data when you think that these patients have failed triple therapies with IMiDs, with proteasome inhibitors, and also with daratumumab in most cases. So what's also important, and this is something that we don't usually follow clinically, although we can if we want to, is really the question of quartiles of exposure. So the longer the exposure remains on these as you can see on those orange bars, the more likely that will translate into a superior progression-free survival based on the quartile exposure. So that is a marker of persistence of the CAR T cell. This is the second product which I personally like more. It's cilta-cel. This is the one that has 2 binding domains. Again, this was a phase 1b/phase 2 study, overall around 97 patients. Similar to the previous one, median age, again in the 60s. So a little bit of a selection bias in my opinion. But you can see that these patients, a good percentage of them had 17p deletion, and some of the cases have 414 or the translocation 1416. Now, what you will see here as a normal theme is that between 7 to 10% of the patients would normally die while waiting for the CAR T. They started with 113 patients, 12 has to discontinue, 8 because of death, so these patients do not have a lot of time in their hands to wait, 2 of disease progression and 2 withdrew. So ultimately you only have that number of cases that eventually ended up receiving the product. So progression-free survival at 12 months, 77%, and the median PFS had not been reached at the time that the original study was reported. As you can see on these plots, you can see that those with the green lines are patients who achieve a very stringent complete response. The blue lines on figure B are the ones who have complete responses or very good partial response or better. And you can see that a significant number of these patients did achieve those endpoints. So patients achieving a response, 97% of these cases were able to achieve a response, with the best overall response being a stringent CR in 67% of the cases. In my opinion, it's more impressive than what we have seen with Abecma, and the product has a much more friendly toxicity profile than Abecma, in my opinion also. So PFS according to response, the blue ones are the curve are the ones who achieve a complete response. You can see 85% 1-year PFS. If VGPR or better if VGPR or PR is around 62%. And you can see the 12 months overall survival of 89%. Keep in mind these patients have failed the 3 best therapies that are available for myeloma, and you still have them living for 89% of them living up to 1 year. In terms of cytokine release syndrome, 95%. This is I'm going to be spending some time in the lymphoma presentation to share with you that this is something that we have gotten used to treat. So patients rarely die of complications like cytokine release syndrome. I would say in this particular study, 1 case they could really associate, and most of them would be HLH and not CRS. In terms of death from the in the population, cilta-cel rated 6, so you can see 6 of 97. Myeloma progression 5, and 3 of them were deemed to be not related to cilta-cel, 2 cases being acute myeloid leukemia. Difficult to sort out that leukemia, and we're still puzzled by that. I have seen 1 case in my clinic that developed AML. Is that because of the maintenance lenalidomide? Is that because of prior alkylator therapy with melphalan? It's difficult to tell in my opinion, because a good number of these cases, over 80%, have failed an autologous transplant. So this is the follow-up of that CARTITUDE study, and you can see that on the blue curve here, those patients who have MRD for 6 months or more did well, and the median, actually 27-month PFS rate of 73% if they were MRD negative for 6 months. However, if they were MRD negative for a full, more than 1 year, 78.8%. So the durability of the MRD is very important in terms of discussion of long-term outcomes of this patient. The next slide is something that I am still very puzzled, and I'm not able to understand some of the aspects of this study. This is what they call CARTIFAN. This is a study that was conducted in China. Again, to give you some background, ciltacabtagene autoleucel was produced by the Chinese, and it was sold to Janssen. The first study, CARTITUDE, was run in the United States, and this study is a smaller study run in China with 48 patients, 8 sites in China, same study population, more than 3 lines of therapy with IMiDs, PIs, and then 1 single infusion of cilta-cel at 750,000 cells. So nothing out of the normal here. perhaps a little bit of a higher dose of cilta-cel. You can see here of 64 patients that were enrolled, only 38 were still ongoing. And this is the part which you can see responses not very different, but what is puzzling is this. When you look at the cases of, out of the 48 cases, there have been 10 deaths during the study. 8 of them are thought to be because of cilta-cel. Things like hemorrhage, I can understand because of low platelets. Sudden cardiac death, this is an older population. Septic shock because of infection. Hepatic failure, perhaps part of HLH. Pneumonia due to, again, the prolonged suppression of these cases and the steroids and so on and so forth. But there are some other side effects that, why would they attribute 172 days later organ failure due to this, or pulmonary mycosis almost 7 months later? So this is certainly some puzzling aspects of this study, but I would say that a little disappointing in terms of outcomes compared to what we're seeing on CARTITUDE-1. Teclistamab is the new kid in the neighborhood, and this is a bispecific antibody. It's, again, also fascinating mechanism of action. So the antibody attracts the T cell, binds through the CD3 component of the bispecific, and then attaches to the BCMA domain, and actually allows the T cell to does the killing also of that, with some direct killing through the BCMA anti-CBMA effect. This is a study that was published recently by Philippe Moreau, and it was a collaboration between the United States and also Europe. And you can see basically these patients have relapsed refractory myeloma, failing more than 3 lines of therapy, including triple class exposure. And again, population, median age of around 62 to 64. Predisposition or the distribution of gender 65 versus 35. So this is the typical distribution in the United States with a slight predominance of male versus female. So I'm curious about your data, whether it's underreporting of males compared to females could be the case. Typically men tend to be less caring about health than women. So that's my personal interpretation of that. Good number of cases having 17p deletion, translocation 414. So heavy cases here. And we can see at the overall response rate is here 39.4% CR or higher. And when you look at VGPR, and which includes everything more than VGPR or VGPR or higher, around 60% of the cases. In terms of duration of response, median of 18 months. So certainly impressive data for this bispecific antibody. It's a continuous treatment, so it's a weekly, and this is probably one of the disadvantages compared to CAR T-cell therapy, which is a one-time treatment. Looking at progression-free survival, median of 11.3 months, overall survival 18.3 months. So certainly impressive. Again, this product can cause, similar to other bispecifics that we have, like blinatumomab, cytokine release syndrome in almost 3/4 of the cases, with neurotoxicity in around 14.5% of the cases. So the last product I'm going to focus on here is belantamab mafodotin. This is a product that, because of the side effect of keratopathy, we tend to be very careful using it. But this was DREAM2 study, open label, 2-arm phase 2 study, around 58 centers in 8 countries, relapsed refractory myeloma, 3 or more lines of therapy. Again, ECOG up to 2. There were 2 doses that were being evaluated, the 2.5 mg per kilo or the 3.4 mg per kilo. And again, this is the population, 97 patients with the 2.5 and 99 patients with the higher dose. Overall response rate is 31% versus 34%. So no difference in terms of response when you look at the higher dose compared to the lower dose. This is one of the concerns, keratopathy, and it actually makes you, puts the patient, the treatment physician in a tough situation, because nothing really works except stopping the drug and giving the patient a holiday. And again, you have difficulty trying to restart this drug once you develop this side effect, but it happens in around 27% of the cases. And then in terms of safety profile, there were 2 deaths in that particular study. Not surprising, sepsis and HLH, which probably is not, or luckily is not very common. Again, these are the responses or survival in terms of doses, not very different between the two dose levels. So this is my previous to the last slide. And I would say that when you compare these three options, in my opinion, the advantage of CAR T-cell therapy is that it's a one-time treatment. You get a treatment, you saw the response, especially with CARVYKTI, 80% 1-year survival, and follow-up encouragingly over 70% at 17 months or so. So very important. Disadvantage, you have to wait for the manufacturing process, long manufacturing time, requires a complex infrastructure, cost could be an issue. In terms of belantamab, it's off the shelf. It's a treatment every 3 weeks, 1 hour infusion, no cytokine release syndrome. Can be treated in the community. The problem is the ocular toxicity. And teclistamab, certainly off the shelf, good responses, as you saw in the presentation, could be given in the community. Challenge is, when do you stop? Again, this is a treatment that is expensive. So these are pretty much the struggle that we have to live every day in terms of what do we choose for our patient. So this is my last slide. Immunotherapies are certainly improving the prognosis of relapsed refractory myeloma. I think that what I am still disappointed at is the cost. It's not a treatment that can be afforded for all mankind, and that's really certainly something that we should do better and try to hopefully continue to do studies that or develop products that can hopefully lower the cost of these therapies. I think it's here to stay. Efficacy even in penta-refractory disease. Treatment-related mortality, I would say, is low. As you can see, you have seen on the KARMA and the CARTITUDE study. The Chinese trial is an outlier. I would say that 8 of 48 cases showing attributable death is concerning. I think that the access to CAR T-cell therapy is limited, so we have 2 waiting lists in our program, and we give the patient the option, do you want to go on Abecma, now I have 1 slot, or you want to wait for the other one in 2 months? So it's not a very pleasant situation to be in, to try to really have a waiting list. You have to wait for a slot for this patient. So teclistamab could perhaps start to affect the market share of this type of treatment. I think that post-CAR T-cell therapy remains a challenge, and I don't know, once these patients fail this type of therapy, it becomes so difficult to salvage them. So with that, I would like to thank you for your attention.
Thank you, Professor Dabaja, for this excellent presentation. And now we'll move to the next speaker.
Yes, thank you, Dr. Dabaja. I have the honor to introduce our next speaker. Is Professor John Apostolidis. He comes from King Fahd Specialist Hospital in Dammam, where is he the leading of lymphoma team with an extensive knowledge, experience, and publication in lymphoma field. I personally have the privilege of working with Professor John previously, and we have learned a lot from him, and we are looking to learn more today. So he will be talking about the treatment of advanced stage Hodgkin lymphoma 2022. Thank you.
Thank you, Dr. Abdul Karim, for your very kind words. I would like to thank Al Musa Hospital and the organizing committee for the invitation. So I'll be talking about treatment of advanced stage Hodgkin's lymphoma. And historically, Hodgkin's lymphoma is the big success story in cancer therapy of the previous century. And as you can see here in this slide, which depicts the deaths from Hodgkin's lymphoma in the US, spanning from 1935 to 2000, you can see that the death rates started to plateau with the introduction of radiotherapy, initially as cobalt, which was crude radiation at that time. But still, as you can see, there was a plateau, possibly suggesting that patients lymphoma. But as you can see here, around 30% of patients at 5 years have progression of the disease, and the efforts have focused on improving the outcome of these patients who actually fail ABVD. These are studies looking at randomized trials, actually looking at the ABVD compared to BCOP, either standard or escalated. And as you can see, there's no doubt, as you can see in orange depicted, there's a significant difference in progression-free survival in favor of the BCOP regimen. But if you look at the gray, which is the overall survival, there's no significant difference. So why is this the case? The reason is, first, as you can see on the left hand up, there's no difference in overall survival. And the reason practically is because you have less toxic deaths from secondary malignancies. As you can see in the left corner side here, this is comparing the ABVD with BCOP. You can see that there's a plateau in the secondary malignancies with ABVD, but accumulating incidence of secondary malignancies with BCOP. And the right-hand slide shows 10-year follow-up of the German Hodgkin's lymphoma study group HD15 study. And as you can see, accumulating risk of secondary malignancies in these patients. And the other thing is also, we should not forget that introducing this regimen as upfront therapy in young individuals puts them at risk of infertility, which you don't have with ABVD. You can overcome it, actually. So this is looking at studies in advanced Hodgkin's lymphoma in patients who achieve an interim PET negative scan, and the UK Raffles trial, which was a randomized phase 3 trial. If we focus only on the patients who were PET negative, they received ABVD 2 cycles if they were PET negative. Then bleomycin was omitted, and they continued with another 4 cycles of ABVD, and with AVD. And as you can see, the progression-free survival was 85%. Very good, excellent results in these patients. Essentially, de-escalate if you have a negative scan after 2 cycles, omit bleomycin. Another strategy is starting with escalated BCOP 2 cycles, and if a patient achieves a negative PET scan, you can de-escalate to ABVD 4 cycles. And we also have the Echelon 1 study in which patients were randomized to rituximab AVD with bleomycin omitted, or to ABVD. And as you can see, there was a statistical significant difference, although not very high, as you can see, in favor of the BV-ABVD arm in terms of progression-free survival. What about patients with interim PET positive scan? These patients can be, in the Raffle trial, were switched to escalated BCOP and radiotherapy. And these patients, as you can see, around 70% of these patients achieve progression-free survival. The other option you can do if you fail ABVD is to switch to salvage therapy and autologous stem cell transplantation. As you can see, the results are fairly good. And in the Echelon 1 study, for patients who were DeVille 4 or 5, as you can see, even if they continued treatment, around 60% of patients would be progression-free, although highly statistically significant in favor compared to ABVD, where only around 40% of these patients would still be progression-free. Just to remind you a few things about the Echelon study, this is the design of the study. So patients were randomized to ABVD or brentuximab vedotin AVD with bleomycin omitted. An update of this study was just published recently in the New England Journal of Medicine. Interestingly, at 6 years, the progression-free survival was in favor of the AAVD arm, but surprisingly, there was also an overall survival benefit in the AAVD arm, which, if you look at the breakdown of causes of death, was mainly due to deaths from secondary cancers in the ABVD arm, which was quite surprising. Most of these were actually hematologic malignancies. There's no clear explanation to this. It was surprising that there were more secondary malignancies in the ABVD arm, although these regimens do not differ significantly, and one could not argue that the brentuximab vedotin has any protective effect on secondary malignancies. But the point of the matter is it did show a difference. Now, what about patients who have bulky disease? Although we're discussing advanced stage Hodgkin's lymphoma, still patients who have a bulky stage 2B or stage 2BE are considered patients with advanced stage disease. So that's why I'm presenting this study, which was just published online in the JCO. So they took patients who had bulky disease, strictly defined as bulky mass at least 10 centimeters, or at least a third of the maximum of the thoracic diameter, as it traditionally has been stated. And if you look at the patient's characteristic, 51% of these patients were stage 2B or stage 2BE. So these patients received 2 cycles of ABVD. They had a PET scan, and if the PET scan was negative, that is DeVille 1, 2, or 3, they received an additional 4 cycles of ABVD, and these were 78% of patients, the vast majority of patients. Now, 22% of patients had a PET scan which was DeVille 4 or 5, PET positive, and they received escalated BCOP 4 cycles and then consolidated with involved field radiotherapy in the initial sites of bulk. As you can see here, there was no difference in the outcome between PET negative and PET positive scans. That excellent progression-free survival rates. And if we focus on the patients who were PET negative on the right hand, either DeVille score of 2 or DeVille score of 3, there was no difference. So one could suggest that it's safe to omit radiotherapy in patients with bulky disease based on this study. What about older unfit patients? Now, older patients, they don't tolerate ABVD, and we have excessive lung toxicity from bleomycin, so it is a challenge how to treat these patients. There was an interesting study which in patients who received initially 2 cycles of brentuximab vedotin single agent, and then AVD 6 cycles, and then continued with another 4 cycles of BV maintenance. Again, the response rates were very good, but, and as you can see, the progression-free survival rates were very good, but there was a 35% withdrawal in this study due to toxicity or adverse events. So it's not the ideal regimen for elderly patients. We also have the BV-Nivo, which is a chemo-free combination. And this induces very good response rates, but the median progression-free survival is only around 18 months in these patients. BV-dacarbazine is a very interesting combination and has minimum toxicity. It induces very good response rates, but again, the median progression-free survival is around 18 months. And finally, the BV-bendamustine, which we use sometimes as salvage therapy in Hodgkin's lymphoma. This has very good response rates, but unfortunately, serious side effects in the vast majority of patients, and in this particular study, there were 2 toxic deaths. So it's not suggested as a good regimen for elderly patients. Now, there's an interesting phase 3 trial up front comparing immune checkpoint inhibitor combined with AVD, which is Nivo-AVD. And this is compared to brentuximab vedotin plus AVD head-to-head. This study has completed its accrual of patients, and hopefully we should have the results of this study in the next few years. Now, these are the conventional standard regimens we use in patients who have primary refractory disease or relapse after first-line therapy. They are either platinum-containing regimens, ifosfamide or gemcitabine-based, and here you can see the response rates. There's no study to show any superiority of one combination over the other. There is a trend to combine these salvage regimens with the novel agents. Here you can see small studies combining traditional salvage regimens with brentuximab vedotin, and sometimes using maintenance consolidation therapy in these patients. And here are combinations with the immune checkpoint inhibitors, as you can see. Again, these are small studies, and there's no comparison with standard salvage therapies in the literature. There is one small study from the Mayo group. No, it's actually international collaborative study. It was actually published as a poster at last year's ASCO, it compared platinum-based combination therapy with the novel combinations such as brentuximab vedotin bendamustine or BV-Nivo. And in the early relapse patients, you can see that there is a trend for superiority in the overall response and CR rates in the novel combinations. Here's a breakdown of the 2-year progression-free survival in these of this study. Although the figures are small, because you can see that the platinum-based were 540 patients and the BV-Nivo were only 60 patients. But again, in primary refractory disease and early relapse patients, you can see that there was a highly significant improvement in the progression-free survival of patients who received these novel combinations. But still, I would argue that you need randomized trials to make the case. This is data from our center. It just shows you our experience with autologous stem cell transplantation in Hodgkin's lymphoma. These are patients which we treated they received salvage therapy, and we consolidated them with single agent melphalan, 200 milligrams per square meter, and these patients were treated as outpatients. So this is outpatient autologous stem cell transplantation. The results, as you can see, are excellent. We have 6-year progression-free survival of 6 years and overall survival of 95% at 6 years. What about the role of consolidation in Hodgkin's after autologous stem cell transplantation? We have brentuximab vedotin maintenance. This is the Athera trial, which compared observation to maintenance brentuximab vedotin with 16 cycles. These were mainly patients who had relapsed within a year of initial treatment or had primary refractory disease or extranodal disease. So these were, in a way, high-risk patients. As you can see, there was a significant difference in favor of the brentuximab vedotin maintenance arm versus the placebo. You can see that the difference in the 5-year progression-free survival was 59% versus 41%. I should stress also that some patients do not benefit from maintenance. These are the patients who relapse beyond 12 months, and those who have a negative PET scan before they go on to autologous stem cell transplantation. What about the immune checkpoint inhibitors? I should mention here, although I should have included a slide, that the defining genetic abnormality in Hodgkin's lymphoma is copy number alterations of chromosome 9q24, which actually is the area of chromosome in which the PD ligand 1 and PD ligand 2 genes reside. So you have copy number alterations of this part of the chromosome, which means you have overexpression of PD ligand 1 and PD ligand 2 in patients with Hodgkin's lymphoma. So it's no surprise that the anti-PD-1 immune checkpoint inhibitors, nivolumab and pembrolizumab, have efficacy in these patients. And this was shown very early in phase 1 studies, where we had very high response rates of patients with relapsed refractory Hodgkin's lymphoma who had failed, in the majority of these patients, had failed autologous stem cell transplantation and even brentuximab vedotin. And you can see here response rates between 65 and 87% and CR rates of around 20%. And if you look at the long-term outcome of these patients in a variety of studies, you can see that the 5-year progression-free survival was around 18%. So there are still a few patients who maintain their remissions just with single-agent immune checkpoint inhibitor. But also, what's very impressive is that 71% of these patients in the Checkmate study were still alive. The same also applied for the Keynote 087 study, in which again 70% of these patients were still alive. But what's also impressive is that patients either with CR, PR, or stable disease have excellent overall survival. This is just focusing on patients who achieved a CR, and this was an abstract from ASH last year. So in the Keynote study, around 25% of patients achieved CR, and as you can see here, highlighted in red here, is that the 44% of these patients still were in remission, progression-free at 5 years, and the overall survival of these patients was 82%. So what I'm trying to say here is that usually patients who fail autologous stem cell transplantation and they go on to an immune checkpoint inhibitor and achieve some kind of response are usually candidates for allo stem cell transplantation. But one could argue with these overall survival rates that it's quite challenging which of these patients you should actually pursue allo stem cell transplantation. Finally, there's a study, a randomized phase 3 trial that compared pembrolizumab to brentuximab vedotin in patients with relapsed refractory Hodgkin's lymphoma. And these are patients who had relapsed post-auto or who were ineligible for auto and had failed one prior line of therapy. They were randomized to pembrolizumab or to brentuximab vedotin. One weakness of the study is that they had to receive up to 35 cycles, and it's hard to give up to 35 cycles of brentuximab vedotin in patients due to the peripheral neuropathy that this drug can cause. But there was a difference, a statistically significant difference in favor of pembrolizumab. As you can see, the median progression-free survival was 12.6 months versus 8.2 months. So the take-home message is that ABVD and BV-AVD are the standard of care for the majority of patients. One could argue which patients should receive brentuximab vedotin up front. I mean, we personally we're selective. We usually treat patients with this combination who are young in age and who have a high-risk advanced stage disease with extranodal sites. Those we would feel that they might not do well. BCOP escalated, there's no doubt, improves progression-free survival rates compared to ABVD, but there's no difference in overall survival, as I mentioned earlier, and this is because of the cost of toxicity, short-term and long-term toxicity. And I should also add the risk of fertility issues with this combination. Maintenance brentuximab vedotin followed by autologous stem cell transplantation is indicated in a proportion of these patients. The immune checkpoint inhibitors in the relapsed refractory setting have significant activity. And as I mentioned earlier, CRs, PRs, and even patients with stable disease achieve prolonged overall survival with a good quality of life. I must emphasize that. And there is a growing interest in combining these immune checkpoint inhibitors or brentuximab vedotin with chemotherapy in the relapsed refractory setting. So thank you very much.
Thank you. Thank you, Doctor, for this elegant talk. Our third speaker will be Dr. Umran Khan. He will talk about new drugs and updated in the management of large B-cell lymphoma. Welcome, Dr. Umran Khan. You have 20 minutes talk.
A long afternoon. Bismillah ar-Rahman ar-Rahim and Assalamu alaikum wa rahmatullah. And first of all, I would like to congratulate Musa Hospital and the organizing team for a very successful program and conference. And I would like to thank for the kind invitation. I have been asked to talk on new drugs and updates in the management of diffuse large B-cell lymphoma over the next 20 minutes or so. It's a huge topic. I would like to cover the salient. I have no disclosures to make. So diffuse large B-cell lymphoma constitutes around 1/3 of all non-Hodgkin lymphomas, and median age of diagnosis is mid-60s, but in Saudi Arabia, we see much younger population, and 1/3 present in early stage, and unfortunately, up to 50% of the patients can have relapsed refractory disease. Relapsed refractory DLBCL has poor outcomes, especially those who have early progression or refractory disease. So, diffuse large B-cell lymphoma is curable. Patients that don't do very well. If you can see, especially those with higher IPI score, their survival is 60% or so. And also, if you look at the outcome based on cell of origin, GCB tends to do better than ABC phenotype. And again, this study compared the overall survival, especially of those, if they progress within 24 months, their outcomes are really dismal. So those patients who do not progress in the first 2 years, their survival at 7 years is similar age, sex, country, match, background population. So it's very important that if they can cross this 2-year barrier, hopefully their outcome is going to be very good. Again, this diffuse large B-cell lymphoma is a very complex. It is not as simple as GCB and ABC phenotype that we can devise through Hansen's algorithm. It is different. We can know this by gene expression profiling, but there is a significant number of patients, around 20% or so, that are indeterminate group. And within ABC and GCB, you have good risk and poor risk as well. So if you further look at the biology of diffuse large B-cell lymphoma, it is quite complex and heterogeneous, and that would tell us why these patients respond differently, despite sometimes falling in the good group. So what is the standard of care? For the last 2 decades, R-CHOP has still maintained to be the standard of care in diffuse large B-cell lymphoma in the frontline setting. There were so many trials. Unfortunately, they were not better than R-CHOP, starting with R-CHOP 14 or R-CHOP consolidated with autologous stem cell transplant, and R-CHOP with R maintenance, R-CHOP with mTOR inhibitors, R-CHOP with lenalidomide maintenance, bortezomib, and R-squared CHOP, and R-CHOP ibrutinib, and ACALA is still ongoing, and we have data on polatuzumab, which will be discussed in the next few slides, and O-CHOP and R-CHOP. So you can see here, some of them have showed better PFS, but the overall survival hasn't been better. However, ABCVP has shown to be effective, but a lot of people don't have experience and also access to Vindicin. Only in some of the Scandinavian countries, they use this regimen. So coming to polatuzumab, it's an antibody drug conjugate, similar to brentuximab or gemtuzumab. It has got potent microtubule inhibitor, MMAE, monomethyl auristatin, linked to CD79, this polatuzumab. And this gets in and causes microtubule disruption and apoptosis and cell death. So this was the phase 3 trial, POLARIX study, that compared Pola R-CHIP with R-CHOP. No vincristine. If you combine vincristine with Pola, it's going to cause a lot of lung toxicity and neuropathy. So if you look at the baseline characteristics, they were similar in terms of IPI and cell of origin, extranodal sites, and so on, and double expressor, double hit. And here, look at the PFS, which was superior to for Pola R-CHIP at 76% versus 70%. So the hazard ratio of 0.73, so it demonstrated 27% reduction in progression or relapse or death. And overall survival at 27 months has been no different, probably a bit early. Again, different treatments, further treatments patients received, it's higher in the R-CHOP group compared to Pola R-CHIP. Again, fortunately, the side effects have not been very different in both groups, and it has been effective in most groups. And if you particularly look at the high risk, age greater than 60, high IPI and no bulk, and ABC seem to have benefit as well. So is it cost effective? I think at this stage, this was just published a week or 2 weeks ago in JCO. At the current list price, it's probably not going to be cost effective. If your QALY is $150,000, but like Canada and UK sometimes negotiate at a national level for a cheaper price. So it may be cost effective at a cheaper price if you want to use for everyone. But I think for high risk population, it may be effective. So in summary, effective with significant PFS at 2 years, safe with comparable toxicity, and probably not cost effective at current list price for everyone, but maybe an option for specific subgroups, high API, age greater than 60, non-bulky, and ABC subtypes. And it has still not received approval, but had received favorable comments by EMA. So again, polatuzumab, rituximab, bendamustine in the relapsed refractory setting. The response rates were significantly higher PET CRs with Pola BR compared to BR, almost 40% versus 17.5%. And again, median PFS 7.5 versus 2, and overall survival 12.4 months versus 4.7 months. And again, if you look at the patients who are refractory to second line or third line or primary refractory, Pola BR had better responses. So now coming to bispecific antibodies, and again, these have no approval so far. So in bispecific antibodies, we all have experience with blinatumomab, so it is similar. On one hand, they bind to CD3, binds to CD3. Other hand, they bind to tumor cell through CD20, causing T cell activation and tumor cell death. So we have got glofitamab and epcoritamab and mosunetuzumab and odronextamab. None of them have approval yet, but available on compassionate basis. So Glofi is every 21 days IV and only for 1 year. EPCO is every 28 days and until progression. So in a year, 27 visits to hospital, and Ondro is up to 35 visits to a hospital. And again, you have got from the recent data, different patient groups that are involved in these studies. So good thing is both have nearly 40% CR rates in this heavily pretreated population with overall response rate around 60%. And again, this seems to be effective in almost all groups, including prior CAR-T, post-auto, and relapsed refractory to prior last therapy. And again, these CR rates are maintained in almost all groups, including CAR-T exposed and CAR-T refractory. So CRS rate seems to be higher in the initial cycles, but later on, none of them are very, grade 3 and 4 are very few. And again, with mandatory DEXA pre-medication, the number has come down significantly in terms of the CRS rates. And again, mosunetuzumab, again, it's a monoclonal bispecific antibody, has shown some decent responses in this heavily pretreated population, around CR rates around 20 to 30%. So there are so many studies ongoing using these bispecific antibodies in the first line, second line, third line, single agent, and combinations. So in summary, of bispecific deep durable responses off the shelf, because we have access to CAR-T is limited, financial issues, logistic issues, and also potential to use in combinations in elderly, first line, second line, coming up in the future ongoing studies. Briefly about CAR-T, because there's going to be another talk by Dr. Zabeja on CAR-T. So we have got 3 CAR-Ts that are approved for diffuse large B-cell lymphoma, axi-cell, T-cell, and lisa-cell in third line setting, but in second line setting only axi and lisa-cell. And the CR rates are around 40 to 50% for all of these, and 2-year PFS 40% for axi and lisa-cell, and Ts around 30%, and grade 3 and 4 severe CRS and neurotoxicity ranging around 10 to 20%. So the CRS, the mainstay of management is steroids and CHOSI, and for neurotoxicity, steroids are the mainstay of management. Coming to this CAR-T in the second line, you have data from ZUMA-7, axi-cell, used in patients who had refractory disease within 12 months of treatment, primary refractory, compared to standard of care. You can see the PFS significantly higher for 14.7 months versus 3.7 months for this very difficult group of population. Like 3/4 of the patients in this study were primary refractory, and double hit 16%, and overall survival not reached yet for axi-cell. Again, this transform study, again looking at liso-cell in the second line setting for these patients who progressed within first year of treatment. Again, similar results with PFS and overall survival, much higher compared to the standard of care. And coming to tafasitamab, it's a monoclonal antibody directed against CD19 in combination with lenalidomide. This has received approval, and so it binds to CD19 and causes cell death through NK cell and macrophage activation, antibody-dependent cytotoxicity. and the responses have been decent, especially those who achieve a very good response or CR. Their median PFS was not reached if they have achieved, for example, CR. And overall survival also seems to be better, but seem to be not so effective in the post-CAR T setting. Again, the toxicity is primarily cytopenias, seems to be comparable. And another antibody that has received approval, antibody drug conjugate, is loncastuximab, and this also seems to have reasonable activity, and further studies are ongoing, but this is something that we have to offer if the patient has not many choices. And finally, on selinexor, XPO1 inhibitor, basically nuclear exporter inhibitor that leads to accumulation of tumor suppressor proteins leading to cell death. And this has got approval as well in diffuse large B-cell lymphoma in third line setting and beyond, and modest responses. Probably not the most attractive drug, but some an option for patients who don't have many options. So finally, the last slide in summary. So R-CHOP is still the standard of care. Probably many of us would use those, just said EPOCH or so for double hit and double expressor lymphomas. And POLA has not received approval, but maybe an option for high-risk groups in future. CNS prophylaxis I have not discussed in the interest of time, but there is a lot of negative data, but all of it is retrospective. We still carefully consider from patient to patient basis in CNS IPI 5 or 6 and testicular site or some other high-risk sites. So if they have relapsed within 1 year, we have got 2 CAR-Ts that are approved for them, Axicel and Lisocel, for early progressors. Otherwise, if they're transplant eligible, you go for traditional RIs, RDHAP, RGDAP, RGDP. If they go to get CR, Beam Auto. If ineligible, you have got POLA-BR, tafasitamab, lenalidomide, and other chemotherapy. And now bispecifics are not still available, but they are available on a compassionate. For example, Glofi is available on a compassionate basis in Saudi Arabia for third line setting and beyond. And of course, we have CAR T cells as well, third line, currently available in the country. So that concludes my talk. Thank you very much.
Our next speaker, Dr. Muhammad Darwish. He's a consultant adult hematology and medical oncology at King Fahd Specialist Hospital, Dammam, lymphoma, myeloma, and bone marrow transplant center. He will talk about emerging therapies update in follicular lymphoma. Thank you.
Assalamu alaikum. So we'll be continuing the talk about the cousin of diffuse large B-cell lymphoma, the follicular lymphoma, which is the second most so it's the second most common non-Hodgkin lymphoma after the diffuse large B-cell lymphoma, and a lot of similarities there, so we may be repeating many of Dr. Imran talks. Most of these follicular lymphomas will relapse anyway, so this is why we need this talk to be in a place in every meeting, I believe. Again and again, we will ask ourselves every time we have a patient whether this patient is really indicated, if the patient is having a relapse, whether they meet the criteria enough to start treatment or not, and was the patient actually previously treated, and how was he or she given, and how did that work. And if we have a chance of biopsying the patient to prove whether there is a transformation or not, this will always be revisited. And if we secure all of this, we should go again with what the patient is able to tolerate, what comorbidities do they have, and how much is the tumor burden, and prognostic factors other than that. So, of course, patient preference would be part of it as well. So, treatment will not go out of these 3 categories, whether conventional treatment, immunochemotherapies, or chemo-free strategies, or the new investigational approaches. Of course, rituximab is the backbone of the treatment in almost all the regimens, with or without chemotherapy. It can be even given as single agent, and if so, may even followed by maintenance. Obinutuzumab is now hitting in the market and coming in early stages of the disease, and even being proved to be efficacious, combining it with the bendamustine. Radioimmunotherapy is an option, external beam radiation, and of course, part of the conventional strategies include this transplant, whether auto or allo. Chemo-naive, the most widely spoken about is the immunomodulator, actually, the lenalidomide, combining it with the rituximab. The PI3K inhibitor like idelalisib is also an option. The EZH2 inhibitor, tazemetostat, is another option. The CAR T cell is always an interesting part of this treatment strategy, and bispecific antibodies like mosunetuzumab is also a good option. Investigational approach including the BCL2 inhibitor like the venetoclax, immune checkpoint inhibitor, the macrophage checkpoint blockade, and the antibodies. Now, going through all of these big trials, no matter what trial you would observe, they all go into a common scenario of if the patient progress within the 2 years, as Dr. Imran said about the diffuse large B-cell lymphoma, it's also true here. Those who progress within the 2 years, the separation of curve is so obvious there, and they don't do well no matter what you do. If you take, for example, these are very few to have phase 3 trial in such a scenario of a relapsing follicular lymphoma, and this is one of them, the Gadolin study, which showed an overall survival benefit with the addition of obinutuzumab to the bendamustine, as I said, and this can be followed by the obinutuzumab maintenance. These patients were rituximab refractory, that's why they were actually shifted to this regimen, which showed a good response rate, and including a significant number of CR in this bad category anyway. So again, if we talk about the progression within the 2 years, as you can see here, this very widely separated curves showing that the overall survival is highly affected, having 50% alive within 5 years, and those who progressed within the first 2 years. While those who progressed afterward, they may have a 5-year survival will reach up to 90%. So no matter what they were given, it's always the case, and in all studies this proven to be similar. And of course, other risk factor can even make it worse, like elevated LDH from the baseline. Again, autologous seems everybody is trying to shy away from autologous, but it seems it's sticking itself there to all of the aspect of whether lymphoma or myeloma, and it's still proven to be efficacious in second CR at least. Of course, it's not used in a first CR except in transformation from the get-go. And still it shows good even overall survival benefit over the traditional chemotherapy, and especially at least in Calgary and the German groups. Although this benefit was a bit less noticed in MD Anderson, I believe. Now, again, comparing whether auto versus allo stem cell transplant, and allo, whether it's from matched, related or unrelated, the allo is showing a bit superior effect, but with more toxicity. So the benefit of it balances the toxicity of that. So it made the auto preferred option in this scenario, especially in those who did not go for auto from the get-go. So still allo is being pushed for a line of therapy after failing the auto stem cell transplant. Okay. So, in a transformed follicular lymphoma, as I said, this is the only scenario where we can go for a transplant from the first CR, but of course it's always preferred to go to a stem cell transplant even if we achieve a second CR. Of course, there is a study which had like 108 patients. All of them had been biopsy proven to be transformed follicular lymphoma, and almost 28% of them were rituximab exposed to prior to this study. And the interval between diagnosis and the transformation, the median time was 54 months, and it showed that the 5-year progression-free survival was 35%, while the overall survival was 50%. Nowadays, CAR T-cell is entering all the discussion of any hematological malignancies, it seems, and I think in near future it will replace the transplant, but we just need to modernize the car and make it a Mercedes type, and adjust the supportive treatment afterward, and reduce the cost as well, of course. So many studies have shown that those CAR T cells is efficacious here. Like the Juliet had around 21 cases out of the total, I believe it was 100 something cases there. 21 of them were transformed follicular lymphoma, and in these cases it showed a good response rate of 52% and a CR rate of 40%, with a 36-month progression-free survival was 36%. The ZUMA-1 trial also had 16 patients in the axi-cell CAR T-cell, and showed even better overall response rate of 82% with a CR rate of 58%, although the duration of follow-up was a bit shorter. And the 3 years overall survival was 47% of all patients. So all of these CAR T cells showed some efficacy, so they will be advanced with time, I believe. The algorithm advice here is to go first to biopsy those who had something worrisome for transformation, and if so, we should go for anthracycline-based therapy, especially that those who was not exposed to it, which is usually the case. So R-CHOP would be the preferred choice here, and followed by auto stem cell transplant and CR1 if they are fit enough. And this can be even followed by another, whether the rituximab maintenance would work here as an extrapolation or not would be of a question. Those who relapse after the auto, of course, should go either to CAR T-cell or allo stem cell transplant if we don't have a good clinical trial that tackle that. Those who are unfit for the salvage treatment can go for BOLA-BR for those who had transformed. R-square, which is the lenalidomide and rituximab, is another option. Gemcitabine-based therapy is also another option. Those who fail this can go direct to CAR T-cell if they are not fit for auto. Of course, with a very high selection criteria. So this is I just left this ZUMA 5 trial to be discussed here, as the axi-cell CAR T-cell therapy was used in the relapse refractory follicular lymphoma, even those who did not have transformation, and the number of patients in total were 124 patients. And the median age was 60 years of age, and the median patient who were previously had rituximab is 3, previously had treatment 3, and half of them almost had being progressed within the 2 years mark. So 24% had stem cell transplant before the CAR T cell happened. And the the median time until that happened was 76 months. And this showed very good efficacy with a follow-up of 30 months, showed a progression-free survival of 39.6 months, and the median overall response rate not reached until the study was done, which was 24 months after the trial. And by then, 81% had been surviving. The toxicity was not significantly higher. They were having only 3% of cytokine release syndrome significant enough, or so grade 3 neurotoxicity was a bit higher than expected in other CAR T cells, as I say. Again, the ELARA latizacel trial was also employed here and showed good efficacy. I don't know if we have, it's almost similar outcome, I would say. So just moving on to the chemo-free strategies. So the BI3K inhibitors is being used here. Many studies have been done to several drugs, including the idelalisib, duvelisib, cobnilisib. All of these were showing good efficacy, but they had very high toxicity, leading to discontinuation of almost 1/4 of the patient of the drug, and so it's not as popular as alternative choices, I would say, so far. The still lenalidomide rituximab compared to these regimens is a bit more popular because of the feasibility, first of all, the more tolerability of it, and the good response rate and the low side effect that is manageable. Only 9% of those patients were held from the drug because of toxicity. Tazemetostat is also being used here, and it is showing a response rate, especially in those who had mutation of this enzyme, or the EZH2 mutation, which were around 70% of them were responding, and the CR rate was around 13. For those who were having a wild type, 1/3 of them had a response, and 4% of them had the CR. And this continuation was not as much as the P1, PI3K inhibitors. Now, bispecific, there are a lot of bispecific coming in the market. Most of them had been enrolled in a phase 1 trial, like the blinatumomab, glofitamab, odronextamab, and the epcortimab. So most of these have been, as I said, in a phase 1 trial. I will just leave the mosunetuzumab for later because it had been into a phase 2 trial. But anyway, if you look into them, they have almost similar enrollment criteria and similar effectiveness almost, with response rate reaching between 80 to 90, and the CR rate between 40 and 70. And the progression-free survival is around 2 years, with very few side effects like cytokine release syndrome or neurotoxicity, which is way lower than those that happening with the CAR T cell. This is the phase 2 I was telling about, and the by antibody treatment of mosunetuzumab, which was used in the relapse refractory follicular lymphoma. It was used in 90 patients. The median number of previous treatment was around 3 lines of treatment. Half of them had been progressed in the first 2 years, so it gives you the high risk population that have been enrolled in this trial, and showed again response rate of around 80% with a CR rate up to 60%. With a good progression-free survival in this difficult category anyway. The last category would be the investigational choice, going with mainly the venetoclax with being a BCL2 inhibitor. There is a contradictory points whether this is really of a good efficacious regimen anyway, and certain trial like the one comparing it with the binda and rituximab wasn't really impressive enough to tell about the efficacy of that, but alone was having at least some efficacy, and with the obinutuzumab also had some efficacy. So checkpoint inhibitor was almost a similar scenario. I don't want to go into details of that. The macrophage checkpoint blockade with the do not eat sign of the anti-CD47 is becoming more popular, and it's almost generalized to almost all kind of lymphomas, including the follicular lymphoma here. So the pathway between CD47 being present is giving a signal to the T cell not to eat it, and anti-CD47 is blocking it, allowing the T cell to attack the tumor cells. This is the mechanism proposed for this drug. There is the study enrolled 28 patients showing that the anti-CD47 antibody together with rituximab showed good effectiveness. This has been used in patients who had been at least treated with 2 lines or above, and showed that response rate is 66%. 24% of them went into CR with very good toxicity. I'm just pointing here that it has been used also in almost all the types of lymphoma, and I just came across the Hodgkin lymphoma is one of them as well. Okay, so this is again, maybe I'm repeating this. I will just go with the algorithm, lumping everything I have said now. It's like a summary of what you should do in a patient with follicular lymphoma when they progress. Of course, it's always advised to take a biopsy if feasible, and to make sure whether the patient transformed or not. If those who received bendamustine should go for anthracycline-based therapy, and the vice versa. Rituximab maintenance could be of an option if the patient did not transform. If the patient transformed after the second-line treatment, especially those who had progressed within 2 years, is preferred to go for auto stem cell transplant. And if they progressed after that, then the options are open to all of these kinds of treatment, including the allo stem cell transplant, CAR T cell, R-square treatment, and the PI3K inhibitors, as well as the antibody treatment, at least the mosunetuzumab being enrolled, equipped here. Those who had late relapse, of course, they can, especially those who have low disease burden, they may go to watchful waiting, and if they are symptomatic enough, warrants treatment, but they are frail, they may go to receive rituximab single agent, or R-square is also tolerable in this scenario. Radiotherapy is also can be employed in certain areas if the symptomatic is because of a certain site being involved. I think this is the last slide of my talk, and I ended here. Thank you so much.
Thank you, Dr. Muhammad, for this nice and comprehensive review. Now speakers are kindly requested to come to the stage for a couple of questions, if we have questions. Any questions? I will ask Dr. John, in the case of stage 4 Hodgkin lymphoma, but high risk, not bulky disease, but high risk, IPI score high, stage 4B high risk. Do you still de-escalate after, if you use ABVD, do you still de-escalate to AVD after 2 cycles if we have complete remission?
Well, the answer is, I mean, if they achieve metabolic CR with our interim PET scan based on the RATHL trial, yes, we will de-escalate. De-escalate means omitting bleomycin. So you can continue with the AVD, but you omit bleomycin. So the answer is yes, even in these patients, if they have an excellent response, DeVille 1, 2, 3 interim PET scan, yes, we do de-escalate.
You know, these patients will have higher risk than other patients to relapse, but based on the study, we have to de-escalate.
Yes, I mean, to be honest, in young individuals who have high risk stage 4 disease, in particular with extranodal disease, we would probably treat them with AVD. We'd probably upfront give them brentuximab vedotin AVD. So in highly selected patients, we would use this combination. We don't use it in all patients, simply because it's very expensive. So I would say around 20% of our patients would receive upfront AAVD, and all the others ABVD. No, we cannot de-escalate because there's no study. I mean, you could say, okay, you know, if they achieve metabolic CR, DeVille 1, 2, or 3 after 2 cycles, would you de-escalate the AAVD to AVD? Well, the answer is nobody knows. And I think, you know, I think there's a study running, to be honest. But there's no sufficient data to suggest that.
I want to ask a question also, if I can, about BCOP. When was the last time you prescribed BCOP to a patient?
Well, the answer is we don't use BCOP in our institution for a variety of reasons. I mean, first of all, because the majority of our patients are young individuals, and as you know, with escalated BCOP, in males you can overcome infertility with storing sperm. But in females, it's very difficult to preserve fertility. I mean, there's no data to suggest that you can store ovarian tissue. Is very complicated. It's experimental. But oocytes, which are not fertilized, you could store. But if you thaw them and then fertilize them, the success rate is very low. So we don't use escalated BCOP because we're exposing females up front to infertility, which is a very sensitive issue in particular in this country. And and most females would not want to be exposed to drugs that expose them to infertility. And because in females in particular, there's very nice studies, in particular from the Scandinavian countries, where they have very good collection of their data, and it's been published by quite a few countries recently, that fertility goes back to normal after 2 years of exposure to ABVD. So there's no risk of infertility after ABVD in females. The other reason why we don't use escalated BCOP is because it causes, it has significant toxicity. It can cause neutropenic fever. There's a risk of death from infections, which we don't see with ABVD. It's very uncommon. And because we have issues with compliance, many patients, young individuals, live very far from the hospital, hundreds of kilometers or miles. We want to play it safe, so we don't do that. We don't give escalated BCOP. If they fail treatment, we would prefer to escalate to salvage and auto in these patients, which shows similar results with escalating from ABVD to escalated BCOP.
Just again, in Hodgkin, like in advanced stage, when you have PET2 is positive, how do you approach at this point? Like,
well, I just said, patients who, if they're DeVille 5, we would switch therapy, although these are very few patients. Usually, the difficult patients are those in the gray zone, which is DeVille 4. These patients, we would, if they were positive after interim PET scan after 2 cycles, we would probably do a new PET scan after 4 and then decide what we're going to do. So yeah, it's a tricky question because as I showed in the PET data, I mean, even 40% of patients who are PET positive at the end of treatment must still be long-term disease-free. So PET is not that accurate, unfortunately, and this is in Hodgkin's lymphoma, which is the prototype disease for PET scans. I mean, in all other diseases, it's very questionable if you can use interim PET scan. In diffuse large B-cell lymphoma, interim PET is useless. We've seen that. Because if you escalate, nothing changes.
I have a question for Dr. Muhammad. Thank you for the presentation. So, in the world of this multiple relapsed myeloma patients, now maybe we don't have the access to all the newer agents. Maybe teclistamab is now possibly being provided as a compassionate release by Janssen. However, I mean, considering that the responses when it comes to blinatumomab, the antidrug conjugate, and Selinix or melflufen also as well, I mean, how do they fit in and out in these type of patients when you have a CAR T cell, especially with the cell doing so good, and obviously with the ida cell as well, and now teclistamab. I mean, would you ever consider using those prior to, if you have the access to CAR T cell and a teclistamab, would you ever consider using these type of drugs with that are less potent, considering?
So I think that it's obviously the answer depends on where you practice. So in the United States, I think that if I were to prognosticate the future, probably they're going to be moved to an earlier stage. So I will not be surprised to see CAR T cell therapy in myeloma following the same sequence that happened with ZUMA-7 and with the Transform study. Now, in terms of the other treatments, I would say that if you don't have access to CAR T cell therapy, then I think that once you fail the four major players, it becomes a matter of choice. I mean, and there is no rationale. Sometimes a patient in front of you think will be a better candidate for KPD. Another case you think, well, selinexor could be a better option here. But before CAR T cell therapy, median PFS have not exceeded 9 months. So everything that you give had a PFS of somewhere between 4 to 8 months. So that's the challenge really, to try to use those other therapies, because what you are doing is you're adding toxicity if you cannot go for the CAR T cell therapy. But if you don't have any other option, I have some faculty who actually have gone back to thalidomide sometimes. And thalidomide, wherever you put it, have 35% response rate, no matter where you put it. So we have had some of those cases, but I would say that of the options after you fail RVD or data-based regimen or KRD, pomalidomide seems to be probably the way we are going nowadays more than other. Panabinostat is an option. Again, PFS are very short-lived, so that's the challenge with what do you give that can give you some durability. Yeah.
Thank you, Dr. Tabeja. My question is, we have now teclistamab available on compassionate basis in Saudi. Would you have any recommendation from practical point of view in terms of cytopenias, infections, and what's your experience?
So we are also, again, we participated in the clinical trial, but it's just approved less than 10 days ago in the United States. So I would say that we're struggling in terms of the schedule of admission, because ideally should be given in the hospital, monitor for 1 to 2 days for the cytokine release syndrome, and then discharge. And then you have to give another bed in 7 days, and it's not easy. So our approach will be to use the first 2 cycles inpatient, where you do them inpatient and then continue subsequent life cycles as an outpatient. In terms of prevention of, I mean, again, these patients are heavily pretreated, so I would certainly continue with the prophylaxis that we normally will do, acyclovir and some, based on ANC of less than 1,000, we can give also some antibacterial prophylaxis. But it's still an evolving game, so I'm sure that we're going to learn with that. CRS is not a big issue. I mean, after all of the experience with CRS, I think that it's treatable. As I showed on the presentation, very rarely patients die of CRS, and there was no HLH reported, which is what we see normally. We would see more common with CAR T cell therapy. So I would say that continue the prophylaxis that you normally will do, considering these patients are heavily pretreated.
You guys who give presented for CAR T cells. So in myeloma, do you think any patients can be cured with CAR T cells? That's a question for you.
I think cure in myeloma has always been more strict to try to use it compared to lymphomas. Somehow with lymphomas, I would say that 5-year survival of 42.6% based on the Yescarta study follow-up of ZUMA-1, you may feel more comfortable using that word. With myeloma, I would say it's too early to say whether these treatments are curable. I personally do not think so. I would say the longest that we may have is probably approaching like 17, maybe almost 2 years, but that's pretty much it. Yeah, with the Abecma, we probably, rarely we could have somebody who passed the 13 months, but for the Carvykti, yes, we have longer survivors in that regard.
Regarding sequence of therapies, would you prefer giving a bispecific before the CAR T cell?
If you ask me, if both are available, I would say that I would probably prefer CAR T cell therapy before, yeah. It's a one-time treatment, 12 days in the hospital, you're done. You don't have to bring them every week. And again, the question will be, if you fail CAR T cell therapy, would there be a role for teclistamab? Remains to be seen. So.
Okay. More of a practical consideration as well is atoximab after DARA. Now, they always talk about the washout period and all that, and there's the data, some MD Anderson, about using isatoximab. But have you used it in that setting, in post-DARA or progression on DARA or refractory to DARA? You have not.
I have not used it, no.
That's the question. That's, so it's either one of them usually. If you fail one, you don't go for the
Okay, thank you so much. We would like to conclude and thanks our distinguished speaker today. Now with the speaker recognition from the organizing committee, starting with Dr. Umar Abdul Jalil. Second speaker for today, Dr. Debaja. Dr. John Abustudilis. Dr. Imran Khan. And our last speaker, Dr. Muhammad Al-Darwish.
Okay, thank you.
دكتور أحمد سليمان.
شو خشبة طويلة.
دكتور عبد الكريم الكهني. Okay, thank you. So now we have 10 minutes break and then we'll go to the next session. Imam.
Assalamu alaikum. We back again. Our session now will start with again with Dr. Mohammed Dibaja, who is well known, and he will speak about update in CAR T-cell lymphoma. Please, Dr. Dibaja, you are welcome.
Thank you, Dr. Kifah, and thank you for the invitation. I want to thank again the leadership of Al-Musa specialist, and especially my dear friend Dr. Ahmad Antar for this invitation and for the great hospitality I've had so far here. So the talk I'm tasked for the next 20 minutes is about updating CAR T-cell therapy for lymphomas. And some of the speakers in the prior session have covered some of the data that I'm going to be presenting. I'm going to try to emphasize it at the end. But certainly the focus will be on only lymphoma, even though we have also a product approved for acute lymphoblastic leukemia. In fact, you have 2 products approved for that. I'm going to focus on the background studies that led to the approval of Yescarta, Kymriah, and Breyanzi, the ZUMA-1, Juliet, and Transcend, respectively. And I'm going to jump onto the second-line data for patients who have failed to respond or progress on CHOP plus rituximab within less than 12 months. I'm going to touch on mantle cell lymphoma, which we have not discussed today. And then I'm going to also focus on follicular lymphoma based on the ZUMA-5 and ELARA. I'm going to share with you some of the algorithms for not only staging and grading cytokine release syndrome and neurotoxicity, but also some tips in terms of the treatment that we have learned over the years. Immunotherapy is everywhere. It's a therapeutic revolution, and you can see that not only medical journals have really taken notice of this, but also we are now in the media outlets, and it's certainly a therapeutic revolution that, in my opinion, will continue to replace conventional chemotherapy or even some of the chemoimmunotherapy regimens as we have seen earlier today. I already presented this slide when I was discussing myeloma. Again, the point to make is that for lymphoma, we have CD19 as the target. At the Mayo Clinic, we are working on other targets that we are bringing to clinical trials. One of them is called BAFFR for lymphoma, and we're also trying to bring also some of these to autoimmune diseases. The difference between the 3 products is in terms of the signaling domain. So axicabtagene or Yescarta uses CD28, and Kymriah or tisagenlecleucel and Breyanzi or lisocabtagene maraleucel, they both use 4-1BB. The difference between these 2 costimulatory signals has to do with the way the CAR T functions. So with CD28, you tend to see a more brisk response, and rarely those patients continue to respond past the 60 days or so. Whereas with the 4-1BB, it's a much slower, gradual increase in response. So you could have patients that may continue to respond past the 30 or even the 60 days. This is the algorithm that I presented earlier into the manufacturing of, and this applies to almost all approved CAR T-cell therapies that use autologous stem cells. So one of the colleagues presented earlier the incidence of large B-cell lymphoma. This was work that actually was published by one of our colleagues at the time at the Mayo Clinic, who looked into the distribution between the different types of lymphoid malignancies based on the National Cancer Database between 2009 and 2011, showing in the blue segment that DLBCL was around 33% of the cases. This is typically followed up by CLL/SLL and subsequently by follicular lymphoma. So large B-cell lymphoma, we know that chemoimmunotherapy with CHOP plus rituximab tends to yield successful outcomes in around 2/3 of the cases. Now, we saw some of the data with the POLA study based on the POLARIX. I would say that we are having difficulty adopting that regimen based on the cost. So the improvement in the progression-free survival or event-free survival was not that significant in terms of magnitude, even though it was statistically significant. To really, in my opinion, it may be used to certain special subgroups of DLBCL. So patients who relapse, the standard of care, if patients relapse and receive second-line platinum-based therapy, typically Rituxan with ICE or DHAP or oxaliplatin instead of the cisplatinum for the DHAP. Typically, we can cure around 50% of those cases, what we call chemosensitive relapse cases with an autologous transplant. However, when we try to do transplant in the past with patients with refractory disease, these are patients who did not have a PR. Again, if you look at the publications, 1987 and 1995, these were the times where PET scan was not standard therapy either. So we know that we can cure less than 15% of the cases. In fact, when we look at our own data, it's even less than 10% of the cases. So autotransplant does not work in chemorefractory disease. So this is data from Scholar One, and they look at 4 databases. And the question is, what is the probability of achieving a complete remission when you have failed 2 prior lines of chemoimmunotherapy? If you look at the MD Anderson database, it's 7% CR rate. If you look at the database from Mayo Clinic and the Iowa University, it's around 7% also. When you look at the Canadian study from the CCTG, it's around 2%. And when you look at the Coral study, it's around 15%. When you look at the pooled analysis, 7%. So the probability of achieving a CR with the 3rd line of therapy, once the patient has failed CHOP, rituximab, or a platinum-based therapy subsequently, is around 7% probability, with an overall response rate of around 26%. So that's really the background or the benchmark for what we need to use to compare. So this is the first CAR-T product approved for large B-cell lymphoma, known as axicabtagene ciloleucel. We use the abbreviation Axicel, commercially known as Yescarta. This was based on the study known as ZUMA-1. They tried to enroll 111 patients on that study. However, when you look at the number of patients that were treated, was only 101 patients, which were distributed as following: 77 cases of large B-cell lymphoma de novo, 24 cases which included primary mediastinal B-cell lymphoma or transformed follicular lymphoma into a large B-cell lymphoma. So as you can see, only 101 patients were able to receive the product, whereas initially 111 were enrolled. So typically this is the ratio of 9 to 10% of patients not ending up receiving the product because of progression of the disease or dying while waiting for this treatment. Median age, a little bit younger than the population normally for that disease. Typically the median age is around 63, so here you can see 58 years of age. Majority, more than 80%, have stage 3 or 4 disease, and almost more than 2/3 of the patients have failed 3 or more lines of therapy. I'm going to focus on this number here, 21% of patients failing an autologous transplant for the entire group, to just show some comparison with other products down the road. But when you look at the responses in large B-cell lymphoma, 49% CR rate. Remember the previous Scholar One, 7%. So you can increase by 7 times the rate of complete remission when we prescribe Axicel compared to what used to exist before. A little bit higher when we look at the transformed follicular or primary mediastinal, almost 10-fold higher. And when you look at all patients, it's around 8-fold higher. So certainly impressive responses when you consider that. Now, if we were to compare this versus a historical control here, so Scholar One, patients who have failed 2 lines of therapy and get the 3rd line, the median survival is only 5.4 months, as shown in the red curve here, whereas with ZUMA-1, median survival is 31 months. So you can see 6-fold increase in survival by offering these patients, in this case, axicabtagene ciloleucel, compared to a historical 3rd line platinum-based or other type of therapy. When you look at the hazard ratio, 70.27, which translates into 73% reduction in the risk of death by prescribing axicabtagene ciloleucel as the 3rd line of therapy for these cases. Also important, this was a single-arm study, but when you look at the comparison here, whether patients, and if we were to go back into the IPI score, age is an adverse prognostic, but the response was similar whether patients were older or younger than 65. When you look at the IPI score of 0 to 2 versus 3 to 4, very comparable responses. Bulky disease, in this case, more than 10 centimeters, similar response whether patients have or don't have bulky disease. And as shown earlier with prognosis, whether GCB versus ABC type, the responses were very comparable. So these products do have efficacy regardless of the adverse prognostic factors that exist in these cases. This data was updated ASH of 2021, showing 5-year survival of around 42.6%. And you can see that the survival curve continues to remain plateau. What is important is the 5-year rate for patients who achieve a CR between day 30 and day 60 is around 64%. So if you have a patient that achieves a response within the first 2 months of CAR-T, that is the group of patients that is destined to do the best, 64.4% 5-year survival. And I think I always like to show this slide to really emphasize the point that partial response is not sufficient. As you can see on the orange curve here, those are the patients who achieve a partial response. The median, in this case, or duration of response was only 1.9 months. So very important to make sure that these patients achieve a complete remission. And normally, if patients by day 90 in our center do not achieve a complete remission, at this point in time, we are offering a salvage therapy, whether in a clinical trial, and then prepare these patients for an allogeneic transplant. In fact, we just published a paper together with a group in Wisconsin and other collaborators from MD Anderson and other centers, showing that around 1 year survival is around 50 to 60% allogeneic transplant, but not everybody is ready for that intervention. So I think that the prognosis of lymphoma, large cell lymphoma, is dictated in the first 3 months of the CAR-T therapy. And I'm going to show you also some data with the other CAR-Ts as well. This was the second product that was approved. This is tisagenlecleucel. Some people abbreviated Tisacel, and it's commercially known as Kymriah. This product is also approved for B-cell acute lymphoblastic leukemia in children and patients up to 25 years of age. So 111 patients again enrolled, median age 56, so a little bit of selection bias. Similar to the previous study, more than 3/4 of the patients have stage 3 or 4 disease, and more than half of the cases have failed 3 or more lines of therapy. Previous study, 21% patient had an autologous transplant. In this study, almost 50% of the patients had an autologous transplant. And as you can see, in terms of outcomes, overall response rate, not different at all, whether patients did or did not have any of the prognostic, adverse prognostic features here. So ABC responses were similar to the GCB, and also the fact that they failed the prior transplant was not influential at all on the outcomes. This was an update on the Juliet study, which was the original study for tisagenlecleucel. Median follow-up of 40.3 months. Overall response rate around 53%. This was an independent review committee with CR rate of around 39%. And you can see also similar to axicabtagene ciloleucel, we started seeing a little bit of a flattening on the curve, a little bit less in terms of numbers, especially overall survival, whereas we were seeing above the 40% or 42.6%. Here it's in the higher 30% or so. This is the third product that was approved for large B-cell lymphoma, known as lisocabtagene maraleucel. Now, the interesting part of this product is that when they manufacture the CAR-T cells, they sort out the CD4 and the CD8. And the idea is that the CD8s are the one who will be more cytotoxic. They will do the initial killing, and the CD4s will be the supporting cells. So we get the product in 2 syringes, and we have to infuse CD8 before we infuse CD4. It's kind of interesting rationale, although it's not really a difference in time. We just infuse one, and then you infuse the subsequent one immediately. So I don't know whether that will be sufficient time to prove that hypothesis, but the point to make is that the product appears to be a little bit more friendly when we look at the incidence of side effects like the cytokine release syndrome and neurotoxicity. Again, similar to the other two studies, around 33% of the patients have failed an autologous transplant, and there were 3 cases that have failed an allogeneic transplant in this particular population. Again, similar to the ZUMA-1 study, the patients who have complete response, typically within the first 2 to 3 months, as shown in the blue curve, have the best survival. The median was not reached for overall survival, whereas the patient that you can see here on the green, the one just immediately below the red curve, you can see those are the partial responses. And it's exactly what we saw with ZUMA-1. So partial response is not good enough in these cases. Similarly, for progression-free survival, showing not reach the median for PFS for patients who were in CR, whereas for patients who were in partial response, as shown in the green curve on the right side, is 2.8 months. So certainly this is an important theme that you will continue to see with other CAR T-cell therapies, whether for follicular or for mantle cell lymphoma. So the logical sequence was, well, we have this product approved for third line or beyond. So what happens if we try to use it in second line? And there were 3 studies that actually were undertaken. ZUMA-7 was a study that compared axi-cel versus standard of care. Transform compared lyso-cel versus standard of care. And the Belinda study, which was negative, compared tisagenlecleucel versus standard of care. Now, the standard of care is not necessarily autologous transplantation, and this is important to keep in mind. The standard of care is a package deal. The patient gets chemoimmunotherapy with a platinum-based regimen. If the patient have a complete remission or a partial response, they go for autologous transplant. If they don't get that, Belinda allowed crossover. ZUMA-7 did not allow for crossover. So that's important to keep in mind in terms of that. The other difference between the 3 studies, which I'm going to summarize, ZUMA-7 did not allow for bridging therapy, whereas Belinda and Transform did allow for bridging therapy, and that could be possibly one of the reasons why the last study was negative, in my opinion. So the second line for axicabtagene ciloleucel, this is ZUMA-7, and the design was I had described earlier. Adult patients, the patient either failed to respond, what we call primary refractory, or the patient relapsed within less than 12 months from the last dose of chemoimmunotherapy with CHOP plus rituximab. Primary endpoint is event-free survival. Patients were randomized 180 patients to axi-cel and 179 patients to receive the standard of care arm. So they did not restrict us to whatever we could choose. In fact, you could choose RICE or ESHAP or GMOX or any of those, as long as it's a platinum-based regimen. And then if patient responded, as shown on the red box, they will proceed to an autologous transplant. Non-responder will become off the protocol. In terms of, this is again the randomization. So what is important to keep in mind here is that of the 180 patients that were intended for axi-cel, 170 ended up receiving axi-cel. So 94% of the patients received the product. When you look at the right side of the slide, 179 patients were assigned standard of care, but only 64 received the standard of care. So you can see that 64% of the patients did not receive the intended treatment, and the reasons are listed below. Some patients requested to be out of the study, but the majority were progressive disease. It's not easy for a patient to fail that have failed CHOP rituximab or relapse within a year to have a good response to second-line therapy. And you can see that here 56 of the patients of the 179 failed, had progressive disease, and 27 have a stable disease. So that's an important thing to keep in mind. And these were the results. So median event-free survival for the axi-cel group, 8.3 months. Median for the standard of care, 2 months only. So you can see here that this study met the primary endpoint and was statistically significant. There is not a single variable that favored the standard of care arm. So axi-cel was superior regardless of age of the patient, whether primary refractory or relapse within less than 12 months, whether patient has a low or adjusted high IPI score, double or triple hit lymphomas or double expressors, or the cell of origin cell type. So certainly this is something that was very impressive to keep in mind. This was a second positive study. This was known as Transform. Very similar design to the previous one. I'm going to put them side by side at the end. But here the event-free survival was 10.1 months versus 2.3 months. So what you can see here is that the event-free survival curve for the standard of care is still the same, 2.2 to 2.3 months. Perhaps a little bit of a better outcome here, but I will be careful in trying to assume that this is better than the previous study. I don't think it is actually. But similar to the previous study, there was not a single instance where the standard of care was better than this second one. So for mantle cell lymphoma is a second disease that basically I'm going to be discussing today. And this is the study known as ZUMA-2. Now, this product is different from Yescarta, even though it's manufactured by the same company. And the rationale is that for ALL and for mantle cell lymphoma, because there is a leukemia phase of the disease, these patients could have a very high burden of circulating mantle cell lymphoma, and similarly for ALL. So what they do here is they try to separate the B cells, which could be the circulating wall, and try to favorably select the T cells and to be able to clean out the process a little bit better. So even though it's the same manufacturing, same virus, same vector, same target, but in this particular case, because of the sorting, the FDA forced them to change the name of the product because of the processing difference of this. So in terms of the characteristic of the study, median age of 65, and what we notice here is that even though this was a small study, phase 2, 68 patients, the population was reflective of the disease. So median age of 65, upper age limit of 79 years. So we're starting to see that these patients are having a significant, or we are really enrolling the right population of cases here. At the bottom of the table, I can show that almost all of these patients have either been refractory to BTK or relapsed during a BTK or relapsed after a BTK or could not take a BTK inhibitor. And the majority of the BTK that was used was ibrutinib, with around a quarter of the patient receiving acalabrutinib. So this is the data for ZUMA-2. Patient, again, 2 or more lines of therapy failure, complete remission rate of 67%, with an overall response rate of 93%. Time to initial response, median 1 month, and the CR rate was around 3 months to achieve the maximum complete remission rate. So this product works quickly and certainly very effectively. Again, when we look at the responses across the different groups, what are the adverse prognosis in mantle cell lymphoma? Typically older age, blastoid variant, high Ki-67, intermediate to high MIPI score, and certainly on all of those, the responses were very similar compared to the lower risk counterparts. In terms of PFS, median was not reached, but the 12-year PFS rate was 61%, and the overall survival at 1 year was around 83%. So very impressive data for patients who were relapsed refractory lymphoma. This was updated at the JCO by Michael Wong from MD Anderson when he looked at the cases, and you can see here at the curves, the top curve, that darker blue color, these were the patients that were in CR within the first 2 to 3 months. Again, median survival was not reached, whereas the 30-month survival rate was 76%. And if you were to look at the red one, is the partial response, which is exactly what we saw with large cell lymphoma. The median survival is 16.3 months, and the overall survival rate at 2.5 years was only 37%. So similar to the previous disease, PR is not sufficient for these cases. Now, there is some data suggesting, mostly in CLL, but I think it could be extrapolated to mantle cell lymphoma carefully, that, and this is still again under clinical trial, suggesting that if you combine ibrutinib with CAR T cell therapy, you can augment the responses without necessarily augmenting the toxicity. So that's probably going to be the next frontier of CAR T-cell therapy. Follicular lymphoma represents around 5% of all hematologic neoplasms. Very heterogeneous disease. We saw some of that data presented in the morning, in the earlier session by Dr. Darwish. And we can see that usually tends to be indolent. Some of these cases can have long survival. Most of these cases, I would say, have dismal prognosis, especially that POD24 group, where we know that survival tends to be very, very bad for those cases. Again, when we look at the first product, this was a study known as ZUMA-5, and you can see that these patients, there were two groups of cases. On the left side of the table, follicular lymphoma, which was the majority, 124 cases. On the right side of the curve were marginal zone lymphomas. So we can see characteristics here, for instance, median age around 60, which is, I would say, a little bit younger compared to the average. But we can see other characteristics here. Previous lines of therapy, more than 3, around 63% of the cases for the follicular lymphoma group, and 24% of them had failed a prior autologous transplant. When you look at the right side of the curve here, the primary endpoint was overall response rate, median follow-up of almost a year and a half, median PFS was not reached for follicular lymphoma, and was around 12 months for marginal zone lymphoma. Median survival was not reached for either one of the diseases. And when you look at the upper side of the patient with follicular lymphoma, we can see 94% of these patients having achieved an overall response rate, complete response in the majority of those cases, almost 80%. This was some updated data at ASH 2021, again showing very similarly those patients with follicular lymphoma in the blue curves here, all group combined, and then the marginal zone lymphomas here. So median PFS for follicular was around 40 months, and the 2-year rate was around 63.4% for PFS, and for overall survival was around 81.2%. So very impressive data. I would say that I would like to see 4 or 5 years data, because we know that follicular lymphoma not unusually can have late relapses. So, but so far I would say the data looks very promising. This is the second product that was presented also in an early presentation. It's known as tisagenlecleucel. And I would say that in this particular disease, my opinion is that both products are very equivalent. Again, when we look at the overall response rate here, it's around 92% versus 94% on the previous one. This product tends to be a little bit more friendly. So when you look at all incidence of CRS was around 49% versus almost 90% for the axicabtagene ciloleucel. So this is a product where I feel more comfortable in follicular lymphoma than I feel with large B-cell lymphoma, especially patients who are of more advanced age with comorbidities. I tend to favor or feeling more comfortable using this product. Not the case with large B-cell lymphoma, unfortunately. Again, toxicities associated with CAR T-cell therapy, and this is pretty much the guide that we follow nowadays. This is published by the American Society of Transplantation and Cellular Therapy, known as the ASTCT criteria. So, cytokine release syndrome, this is a very nice review by my colleague in our program, Hemant Murthy, that we wrote in around 3 years ago. And I would say that it's potentially serious complication of CAR T-cell therapy, especially if not treated earlier and if it progresses to HLH or hemophagocytic lymphohistiocytosis. But overall, nowadays with the monitoring algorithm that we have in place, I would say that we have not lost any patient to cytokine release syndrome since we started the program. We don't understand the exact mechanism, but we feel like part of it is because of CAR T-cell activation and expansion. But also remember, these CAR Ts are secreting those inflammatory cytokines and are recruiting macrophages to come and help eliminate the lymphoma. So probably a combination of both causing the side effect. Symptoms could be simple. Those of you who have treated patients with CAR T-cell therapy, fevers typically happen between days 2 to 5. Typically treated, I would say, once the patient starts having hemodynamic compromise, that's when things can get a little bit more concerning. So the grading system, any temperature of 38 or higher without any hemodynamic compromise, whether hypotension or hypoxia not being present, is grade 1. If patient have suddenly hypotension but corrects with IV fluids, that's grade 2. Or if the patient requires just a couple of liters of nasal cannula. If the patient starts requiring vasopressors, is around grade 3. Or if they start requiring high flow nasal mask or non-rebreather mask. Now, this is one of the improvements over the CAR-TOX criteria that was present earlier, because before, BiPAP had no position. So if a patient had BiPAP, nothing existed in the CAR-TOX criteria. But here, if the patient requires BiPAP or CPAP or any of those for increasing the pressure of the flow of oxygen, then those will be automatically grade 4 criteria. If I have to leave this conference with a message, I would say that even though you are 100% sure that the patient has cytokine release syndrome, it's always important to rule out any source of infection. These patients have central lines in place. These patients have low immunity. They have been on chemotherapy. So always rule them out as you normally will rule out any other sites of infection. This is a review that we wrote with Julio Chavez from the Moffitt Cancer Center and our group in Mayo. And we look at what are the risk factors for neurotoxicity in patients who receive CAR T-cell therapy. And number one is the product itself. So we know that Axi-cell has a much higher incidence of neurotoxicity compared to Tisa-cell or compared to Lysocell. High tumor burden is another risk factor for toxicity. So we know that the much higher burden of the disease, the more likely. Bone marrow involvement, this is more common in ALL, but certainly with some of the lymphomas involving the bone marrow, like follicular and so on. And the severity of CRS can sometimes predict for a more severe neurotoxicity. These cases are more tricky, and you have to really examine the patients every day. They could start just having some disorientation, confusion, difficulty finding words, but then it may last for a few hours and sometimes several days. The good news is that it responds well to high-dose steroids. It has a biphasic presentation. The typical phase 1 will happen concurrently with cytokine release syndrome. That tends to be milder. But there is a separate phase, what we call the phase 2 of neurotoxicity. Happens usually beyond 5 days and tends to, by then the CRS would have resolved, and the onset could be later with certain CAR T-cell products. We have seen that with some of the lysocaptagen cases, where you can see that around day 8 or so. So this is how we score the patient. There is what we call the ICE score. And typically we ask the patient 4 questions, the year, the month, the city, hospital, but you can design your own set of questions. Then you tell the patient to point, to name 3 objects. You point at them. Typically will be the television in the room, will be the door, will be some items in the room. And then you will ask them to write the same sentence every day, and you start seeing that the patient start to have an abnormal handwriting. That's when you know that it's starting to happen. And finally, the ability to count backwards. So we tell them to count from 100 to 0 in decrements of 10. Again, you have to look at the patient in front of you, where sometimes you need to adjust this according to what you expect will be the mental or intellectual capability of the patient. But then, if a patient scores any point here, then automatically becomes grade 1. So any score of 7 to 9 is grade 1, and then 3 to 6 grade 2, 0 to 2 grade 3, and 0. Typically, by the time patients are grade 4, those patients tend to be a little bit difficult to treat. ICANS stands for immune effector cell-associated neurotoxicity syndrome. My drug of choice for treatment is Solimedrol. I personally find it a little bit more difficult to use Decadron than Solimedrol. With Decadron, unfortunately, you don't have mineralocorticoid activity, and I tend to see sometimes, especially if you start a patient with cytokine release syndrome, you give tocilizumab, they don't respond, and you give Decadron. Those patients tend to have a little bit more third spacing, and that could be a problem with Decadron more so than Solimedrol. Typically, I start with something like 250 milligrams per day, and I can escalate to as high as 1 gram per day And I usually tend to be very aggressive in that. Now, what are the take-home messages that I have for my presentation today? I think that CAR-T has revolutionized the treatment of large B-cell lymphoma, mantle cell lymphoma, and follicular lymphoma. And these treatments are going to be here. I think that in 10 years from now, probably all of these will be replaced by either smarter manufacturing. We may be using something different than viral vectors. I think we're going to start using, probably moving into the area of nanoparticles to see if we can use that transduction or transfection using a different mechanism. But I think the encouraging part of this presentation is that we are seeing 5-year survivals of more than 40%. With Axi-cel, 42.6%. If patients achieve a CR early, so almost 2/3 of the patients could be alive several years later. So is this a cure? In my opinion, probably a functional definition of cure. We know that these numbers are interesting because, and this is not just surviving with disease. We know that if a patient fails CAR T-cell therapy based on a consortium study, that the median life expectancy is around 6 months only. So you would expect that these patients, most of them will be probably having a durable and longer sustained remissions. Second line of therapy, only 2 products are approved, Axi-cel and Liso-cel, and there is certainly better event-free survival compared to standard of care in these cases. So certainly the challenge at Mayo Clinic is that we don't get those patients immediately on the second line. So those patients are in the community, they do the PET scan, there is progression, the physician go ahead and start with RICE and then refers the patient to us. So we are kind of waiting sometimes for that response, but certainly that's a group of patients that, in my opinion, would benefit still now. Where I struggle a little bit with this study, and believe it or not, autologous transplant has become the cheapest modality nowadays for treatment of lymphoma. But is it the same if you have a patient that relapses 1 month after CHOP-R versus one who relapses 11 months after CHOP-R? They are both still within a year. So that's the area where we're still struggling. I personally, if those patients who are still within a year but closer to the year, I still will consider auto transplant, provided that the PET scan is negative. So the Deauville score has to be 1 or 2, and barely 3, in my opinion. I think for follicular mantle cell lymphoma, the data is impressive, but again, median survival is still less than 3 years, so we need to see more data here. They are very durable. I would say with mantle cell lymphoma, you can see the follow-up of 2 years being very sustainable. And toxicities are unique, but certainly very manageable. So this is something where if you have a good multidisciplinary team, you could manage these cases very successfully. So thank you again for inviting me to present at this forum, and I will leave the question for the question and answer session.
Thank you very much, Dr. Debaja, for the very nice presentation. Now it's my pleasure to introduce Dr. Riyad Faqih, who will present about advanced treatment in CLL. Dr. Riyad Faqih is a consultant in the section of hematology, stem cell transplant, and cellular therapy at Oncology Center of King Faisal Specialist Hospital and Research Center, Riyadh, with an American board in internal medicine, hematology, and oncology. Dr. Riyad is also the head of the clinical research department at King Faisal Specialist Hospital. Welcome, Dr. Riyad.
Thank you, thank you. Can you hear me well, and can you see my slides?
Yes, it's clear.
Okay, excellent. So I'm sorry I couldn't attend because I'm on call, and I would like to thank the organizers for inviting me to present in your conference. So basically, I was asked to talk about advances on the treatment of CLL. These are my disclosures. But I have no financial relationship with commercial interest with any of these entities. And this is my agenda, so I'll do a small introduction, then we'll talk about the advances. And I split the advances into 4 classes: the biology of CLL, novel agents in CLL, the advances with the combination therapies, and supportive care. So as you know, it's the most common leukemia in the West, while it's not the most common in Saudi Arabia, because this is a disease of elderly, and as you know, the population in Saudi Arabia is a pretty young population. So because it's a disease of the elderly, fitness and comorbidities come into play on how we choose therapies and how we manage these patients. Males are more frequently affected than females, and whites more than any other ethnicities. And there is a familial form, actually, which we tend to see more than in the West because of the higher rate of consanguinity in the kingdom. And this familial form is pretty much the same as the sporadic form, with the only difference being the presentation at an earlier age, which we see it a lot, CLL patient at the age of 35, 40. So this is not infrequent in our clinics. Now, the disease is most of the time is asymptomatic, and the diagnosis is incidental. The patient would do labs for something else, and then high white count and lymphocytosis will be detected. But it can also present, if not detected incidentally on a blood test, as enlarged lymph nodes, marrow impairment signs, anemia, low platelets, infections, hypogamma, autoimmune phenomenon, and sometimes it presents as Richter's transformation. Undiagnosed CLL can present as Richter's transformation. We don't treat everybody, as you all know, but for constitutional symptoms, marrow failure in the form of thrombocytopenia, anemia, autoimmune phenomenon not responsive to steroids, massive organomegaly in terms of splenomegaly or lymphadenopathy, progressive lymphocytosis, quick lymphocytosis, we tend to start therapy for these patients. And watch and wait is still a valid option, even in high-risk patients, 17B deleted, for those who don't have any of these symptoms. Also, in the relapsed refractory setting, watch and wait is still a valid option. When we make our decisions on how to treat these patients, so we split these patients into factors, into disease-related factors and patient-related factors. In disease-related, we split them into high-risk patients versus others. Now, in the past, 11q was included in the high-risk subcategory, but nowadays, with the advent of anti-CD20 molecules, 11q has lost its significance in terms of, being a bad risk sign. So here we have the unmutated patients, 17p deleted, and complex cytogenetics are classified under high risk. And then we have patient-related factors, and these are the age, creatinine clearance, and other comorbidities. The same factors apply actually for the relapsed refractory setting, but here we also include into the decision-making process, we include what the patient received in the front line and how long or how much benefit they got from the treatment they received in the front line. In the old ages, the therapeutics were all directed against the DNA, DNA-breaking agents, typical chemotherapeutics. But then we got the antibodies against the surface molecules on the CLL, and the first one was rituximab, anti-CD20, and then we got a number of other anti-CD20. Nowadays, we have B-cell receptor antagonists in different forms, whether acting on the surface of the cell or on the downstream pathway like the BTKs, PI3 kinase inhibitors. We also have the BCL2 inhibitors, like venetoclax, working on the apoptotic pathways. Also, we have a lot of immune molecules working on the surface antigens in the form of CAR T cell, biclonals coming into the pipeline. So over the years, we've seen many trials that established the standard of care in CLL. And here I mentioned some, but these are not all the trials. We have a huge amount of data and a huge amount of trials and patients treated on trials for CLL. The CLL-8, which established FCR versus FC, CLL-10, FCR versus BR, 11, Resonate, ECOG, Alliance trial, the Illuminate, CLL-14, Elevate, and then we have a number of trials, new trials, Murano, Captivate, and the GLOW. So we have a huge amount of data that guide us on how to treat these patients. And this is how we got into this, recommendation here based on this NCCN guidelines. So for a patient with non-17p deleted CLL, these patients, can be treated with ACALA, with obinutuzumab or venetoclax, obinutuzumab or zanubrutinib, plus many other regimens, and in some circumstances, when you don't have deletion 17p and the patient has mutated immunoglobulin, then these patients may be treated with chemoimmunotherapy, and these patients are expected to have a very long progression-free survival when treated with chemoimmunotherapy. So this is still my practice. Actually, patient with a mutated, fit, and non-17p, I would aim to treat with chemotherapy because these patients may end up without progression for 10 years without receiving any treatment with only 6 months of therapy. Now, for the relapsed refractory and for the 17p, we have another set of recommendation. And here you don't see chemotherapy because basically chemotherapy will give you a short progression-free survival. So it's not worth to use, chemoimmunotherapy and get the risk factors for only a short survival. Here you see a combination of monoclonals and new molecules or small molecules or combination of small molecules together. So talking about the advances, we have, as I said initially, I split them into the biology, novel agents, combination, and supportive care. So in terms of biology, we know that mutated CLL has a better prognosis. Okay, we knew that a long time ago, since 1999 from this publication. And then we got to learn that not all mutated immunoglobulins are the same. Some mutated patients will act or behave like unmutated, okay? So nowadays, we know much more about this, and probably this, what we call subsets of mutated immunoglobulin will come into practice in the soon future, and these may define subsets of CLL where the behavior is different as compared to the others. So here you see the subset for the red line here. You see very indolent and time to event is very long. So this is a very indolent form of CLL. While you see the subset 2, it acts as TP53 actually. So this is a mutated immunoglobulin, but it's acting like TP53. And then you see here the subset 8, which is known to have the highest risk for Richter transformation. So this business of stereotypes of the immunoglobulin molecule will come into practice soon. Then, of course, you all know about the minimal residual disease. This is a very handy tool to determine the depth of response. And you all know it started with the B-cell ALL and B-cell malignancies in general. Basically, what it says, to achieve relapse or deep remission, you need a very deep control of the disease. And the ways you detect the disease will tell you how deep you went into your treatment. So if you rely on morphology, you only have a small reduction and probably not a curative reduction, while if you rely on NGS, flow cytometry, and other techniques, then you may be able to detect deeper remissions and as such plan the cure. So the MRD data from the trials show very obviously that MRD negativity is related to progression-free survival, and probably MRD detection and monitoring will become standard in the CLL treatment. Here you see the Murano trial, and you see the blue curve. These are the patient with detectable MRD versus the patient with detectable MRD. So very big difference in the progression-free survival. And the CLL14, which is the venetoclax Gazyva versus chlorambucil Gazyva, the same thing you see here. So in green is undetectable, and in red is high MRD. Same as was published recently in the GLOW study that compared ven ibrutinib to chlorambucil Gazyva, and here you see MRD positive in a blue curve versus MRD negative in a blue curve versus MRD positive in green curve. So very different progression-free survival, very statistically significant from different trials, and probably MRD will become standard of care in CLL. How about novel agents? You know, the covalent or irreversible BTKIs, we've used them for a number of years. So ibrutinib, we started to use this in 2014 for the relapsed refractory and 2016 for frontline. Then we got acalabrutinib and zanubrutinib, second generation BTK inhibitor with different toxicity profile as compared to ibrutinib, and pretty much maybe similar activity, maybe a little bit better than ibrutinib. We also have two covalent in the pipeline, tirabrutinib and orelabrutinib. And then the new agents that will become standard soon are the non-covalent or reversible BTKIs. And the good thing about these, they work on the C481 mutant BTK, which results in cross-resistant to all covalent BTKIs. So here we have pirtobrutinib, nimabrutinib, and luxepitinib, as well as vecabrutinib, which all seems to work on C481 mutant BTK. Now, with the use of these new non-covalent, we are also facing resistant mutations. So there are a number of mutations identified, and these are non-C481 BTK mutations, and these will result into resistance and the cross-resistance across these non-covalent reversible BTK inhibitors. Other covalent inhibitors in the pipelines are the TG1701 and the DTRMWXHS12. And this agent is being studied in combination with pomalidomide and everolimus. There are other non-covalent inhibitors in the pipelines as well. There are 4 actually: fenebrutinib, HMPL-760, TT01488, and BN102. And there is a new class of BTK inhibitors, and these are called the degraders. So basically, they degrade the BTK, and there are 3 agents advanced in phase 1, phase 2 trials now, and soon they may embark on phase 3 and then go to the market. The other novel agents class that I want to highlight is the newer generation BCL2 inhibitors. You know, venetoclax, we've used venetoclax in the frontline and that's refractory for a number of years, but now we have new BCL2 inhibitors. Here you see the APG2575 or lisaftoclax, and basically how it works, it triggers caspase-mediated apoptosis of the CLL cells. Here you see the phase 1 trial. So it's a collection of B-cell malignancies, but in this collection, they had 15 patients with CLL, heavily pretreated and elderly population. So here you see the responses of all these patients on this phase 1 trial. And then I will move to another biologic or novel therapeutic approach, which is the combination. It's not novel, but basically, you know, ibrutinib mobilizes the CLL cells, and then venetoclax, you know, makes these cells lyse. So BTK inhibition increased the BCL2 dependence in the CLL, and then as such, the BCL2 inhibitors would work better. So the question with the combination is 1 + 1 = 3, not 2. And we have a number of combinations being studied in the front line. We have ibrutinib with venetoclax. We have triplet ibrutinib, venetoclax, obinutuzumab. We have the same triplet just for deletion 17p. We have acalabrutinib, venetoclax, obinutuzumab, zanubrutinib, venetoclax, obinutuzumab. And in general, looking into these combinations, when you combine BTK and BCL2 inhibitor, you see the undetectable MRD in the bone marrow around 70 to 75%. So this is what you expect with these combinations. So here we see the frontline venetoclax plus ibrutinib in CLL. We have the MD Anderson trial, which was a phase 2 trial, and then we have the Captivate trial. And the Captivate trial is looking into starting ibrutinib, then ibrutinib venetoclax, then another randomization. Depends on whether these patients are positive for MRD or negative. So here, this study will answer many questions, whether an undetectable MRD CLL after this combination, do you need to keep these patients on ibrutinib or placebo, and then later on decide what to do. And for MRD positive, it's randomizing these patients to ibrutinib alone or the combination, to continue on the combination. And here you see some preliminary data, very nice MRD negativity from both the MD Anderson trial and from the Captivate. There is a good number of other trials on the front line looking into different combination. We will see the data on a number of these. Here you see the GLOW study. So GLOW study was recently, we got the data recently on this study, and basically GLOW is ibrutinib followed by ibrutinib plus venetoclax versus chlorambucil obinutuzumab frontline randomized trial. And here you see the progression-free survival of these two combinations. Here you see the MRD negativity, very statistically significant MRD negativity. The other combination is acalabrutinib with BCL2 inhibitor venetoclax and anti-CD20 antibody obinutuzumab. And you see here in this trial, you see the sequence of treatment. They start with acalabrutinib obinutuzumab to decrease the load of the disease, then venetoclax, and then later on a patient with undetectable MRD may stop the treatment, while patients with positive MRD will be randomized to different other combination. Here also we see very impressive MRD negativity, as you see after cycle 16, 75%, and here also in the peripheral blood, 87%, so higher than the marrow. The other combination is ibrutinib, venetoclax, and obinutuzumab, and this is the CLL2 GIVE study, and this is restricted for deletion 17p patients. And here also you see a good number of responses. However, the MRD is not as impressive as in the non-17p deleted patients. This is another trial for the 17p deleted, also another triplet, zanubrutinib with BCL2 inhibitor, venetoclax, and obinutuzumab. And here you see the schema of the trial. Again, this is also for 17p deleted. And here you see at 8 months, around 77% have undetectable MRD in the marrow. In the peripheral blood, the MRD is higher a little bit. So pretty impressive result for 17p deleted patients. Here's another trial, and this is the CLL13. This is comparing chemoimmunotherapy to a doublet venetoclax rituximab or venetoclax obinutuzumab, or venetoclax and or gazyva ibrutinib with venetoclax, so triplet. And here you see the result of the triplet in terms of undetectable MRD in the peripheral blood. You see with the triplet 92%, but this is peripheral blood, not marrow. And these are statistically significant as compared to the chemoimmunotherapy combination. So the last area that I will tackle in terms of advances in CLL are the supportive therapeutics. You know, CLL patients, you know, these are elderly patients. They have comorbidities and they get infections, and we use some supportive treatment to avoid these complications, like growth factors, antimicrobials, immunoglobulin replacement, vaccination, and autoimmune cytopenia. Also, we use some supportive treatment for that. Now, the only advance in this area was the knowledge about the response to vaccination in these patients, and we got this data from the COVID vaccination. Again, as you know, these patients are elderly, they have advanced disease, hypogamma, so their immune response is weakened. And this is a study here published in Blood Advances for 530 patients that they were checked for COVID antibodies after 2 doses of COVID vaccine. And as you see, the surprise was, you know, in patients on venetoclax and BTK inhibitor, 0 response, actually very impressive. this is something that we didn't know in the past. We knew that patients on anti-CD20 don't respond well to vaccination, and here you see it, but the impressive result of BTK plus BCL2 inhibitor zero response is surprising, while BTK inhibitors alone also are associated with poor response. As you see, only a quarter of these patients responded. Venetoclax is associated with poor response, but to a lesser degree as compared to BTK, so a half of these patients responded. The other paper that we see along the same line here is a population of CLL patients versus healthy donors. So these patients were vaccinated, and the amount of response was checked and compared for the CLL patient versus the healthy donors. And as you see, so these patients are not on treatment. Even by giving 4 doses, you don't get 100% protection, while in healthy volunteers, with 3 doses, you get almost 100% protection. So this is something to pay attention with the COVID and the new viruses and the new infections, that these medications, though are small molecules and targeted, but apparently they alter the immune system significantly. So what we need for the future, we need, trials having novel therapeutics as control arms, not only, old therapeutics that we already know they're not as effective as the novel therapeutics. We need treatment decisions to be based on MRD status and the depth of response. The sequencing data is something that, we don't know a lot about it. And the biggest question is combination progression-free survival, when you use combination of these small molecules, better than sequencing progression-free survival if you use venetoclax until it fails, and then ibrutinib or acalabrutinib and vice versa. Is this combination PFS better than the sequencing? We don't know. And the other thing that we know a little is that single agent may select for resistance, and this may be a reason, for combination to be better than sequencing. The resistant to novel combinations, we don't know a lot about it. When you use, BCL2 plus BTK inhibitors, and then you get resistance. So what's the basis of this resistance? We don't know a lot about it. And the last question, because we have tons of patients on clinical trial, prospective, randomized trial, can artificial intelligence answer some of these questions? We still don't know. With that, I will finish, and I'll leave the question, I guess, to the question and answer section. Thank you.
Thank you, Dr. Faqih, for this nice and updated lectures. Our third speaker for this session is Professor Elias Chpour. He's a professor of medicine in Department of Leukemia and MD Anderson Cancer Center. He's actively involved in the development of therapeutic research in leukemia, and over the last 5 years, he was assistant in developing multiple chemotherapeutic and biological agents in leukemia, and his lecture is recorded.
Shall I start? Hold a second. I want to make one change, please, because it's November, correct?
Yeah, no.
I start recording now. Okay, can I start?
Yes, doctor, please.
Okay, thank you for the invitation. I'm Elias Chpour from MD Anderson Houston, and I want to talk about CML therapy in 2022 TFR reality. So CML has been transformed from being a deadly fatal disease with a survival at the long run being dismal at 10%, with transplant being the only option. Today, CML being a chronic disease indolent with an excellent outcome, survival at 10 years above 90%, due to the fact that we have multiple TKIs available to us, and transplant is only offered for a subset of patients who failed multiple therapy. So here is your survival curve from MD Anderson. Again, you look at the 10-year survival in CML patients is 90% and higher. That means when we see a patient of clinic, the bad news to deliver, you have cancer. The good news is you can live a normal lifespan. Then we compare survival of patients with CML to normal population. And here you can see overall, the 5-year relative survival compared to normal people is 95%. And in patients who achieve a CCYR, the relative survival is 97%. It goes to 100% in responding patients. So essentially, somebody with CML today who can take TKI and respond so well can expect to have a normal lifespan. So we have multiple TKIs available today in 2022. What approved is listed on the left side of the slide with imatinib, nilotinib, dasatinib, and ponatinib, as well as bosutinib, and recently we had asciminib available. And we have a new promising agent such as HQP1351. We will see that at ASH. We hope to get this drug approved soon. So in a frontline setting, we have 4 options today. And I'd like to highlight that dasatinib is 100 milligram per day, FDA approved, although at MD Anderson we're using 50 milligram per day. In the second line therapy and the third line therapy, we have the second gen TKI, be it nilotinib, dasatinib, and bosutinib, as well as ponatinib and asciminib for patients who failed to TKIs and more, and or acquired T259 mutation. In advanced stage disease, we moved from TKI alone to combination of TKI and other agents. So important questions are being asked today in our practice. What is the best frontline TKI therapy? Do generic do as well as branded imatinib? And when do we use second gen TKI? Endpoint of therapy being CCYR or durable deep molecular remission. And what is the aim of therapy? To have survival improvement or moving into what we call treatment-free remission, long-term side effect and the cost, role and timing of auto transplant, modeling of CML, and TKI discontinuation. We'll focus on it today, and how we sequence subsequent therapies and salvage therapies in CML. So 5 factors determine how I use my drugs in a frontline setting. Depends on age, aim of therapy, cost, CML risk, and comorbidities. Let's tackle age first. Younger patients, we aim to induce a deep molecular remission and treatment-free remission by thereafter, and therefore I do favor second-gen TKI. My drug of choice is dasatinib, alternatively bosutinib. In older patients, the goal of therapy is survival benefit, and therefore treatment discontinuation is less relevant than imatinib is a good standard of care. Cost plays a role, and whenever there's out-of-pocket money, expensive drugs, generic are as good as branded drug. CML risk, somebody with high surface score disease, I do favor second-gen TKI to avoid transformation early on and improve survival. In contrast, low surface score disease, then I use imatinib. And finally, comorbidities, patient comorbidities should be optimized, and we have to select TKI that interfere the least. For example, somebody with pleural, with lung injuries, I will avoid dasatinib because of pleural effusion. Somebody with a vascular event, I will avoid nilotinib. So how to sequence therapy in Houston today? And here what I do, frontline therapy is dasatinib 50 milligram per day as our drug of choice. If I fail, then ponatinib to be given, and I will adjust the dose, 45 milligram starting dose, and reduce to 15 once a PCR of 1% or less. If I don't have C59 mutation, I may use a lower dose and adjust thereafter. If ponatinib cannot be given for whatever reason, then bosutinib is an alternative. If I start on imatinib therapy, then dasatinib or bosutinib, and if I fail, then ponatinib. You can see here, we do avoid nilotinib because of the risk of vascular events, cumulatively up to 25% or 2.5% per year. And for patients who have intolerance, I will adjust the TKI dose. I will optimize supportive care before I make a change to other TKIs. At MD Anderson, we're using dasatinib 50 milligram per day. The rationale is in a decision trial, when dose was reduced, there was no compromise on efficacy. In a phase 1 trial, the drug was found to be effective at a lower dose. Therefore, we decided to run a trial with 50 milligram per day. By doing so, we've shown that 50 milligram per day was as good as 100 milligram per day. However, the safety profile was much better. You can look at the MMR, for example, at 12 months. With the 50 milligram per day, it's 94% compared to dasatinib 100 milligram being 83% and imatinib being lower. Why this efficacy is better with dasatinib 50 is because of less interruption. We have a better safety profile with less pleural effusion. Subsequently, we did what we call propensity score matching, comparing dasatinib 50 to 100 milligrams per day, and we've shown that dasatinib 50 is as effective, if not better, than dasatinib 100 milligrams per day when it comes to MR4, MR4.5, and CMR rate. However, the drug was less toxic, 50 milligrams per day, with the criteria for of pleural effusion being 3% compared to 10% for dasatinib 100 milligrams per day, less interruption, and therefore we have a better event-free survival, fail-free survival. Survival did not matter. So we're moving from 50 milligrams from 100 to 50. In Japan, our colleagues did use a lower dose, even at 20 milligrams per day, for patients who are 70 years and older. They reported MMR at 12 months of 60%, historically being 40% or less. Why? Because we have less interruption, less pleural effusion, and a better outcome. So back to imatinib therapy. Imatinib has been set as standard of care for CML based on the ARIS trial. The 10-year survival is 83.3%. The cumulative rate of CCYR being in 83% as well. The long-term outcome is excellent. I would like to highlight, however, one thing very important. The rate of transformation does culminate the first 2 years at 2.8% and then drop to 0%. Means the outcome is highly predictable. As soon as you have a deep response obtained, then as long as the patient is taking his medicine or her medicine, the outcome is predictable with no events down the road. So here the event again seen the first 2 years, and then thereafter there's no event seen. The outcome of CML does depend on early responses, because once you have a response obtained, very unlikely to have a transformation down the road. Now, despite the crossover design between the two arms, and those who had imatinib therapy had a better survival. 6 months crossover and a 10-year survival, there's a difference of 5%. So that tells us that somebody with CML, we should start effective therapy as soon as possible, because waiting for longer will compromise our outcome. Here we have 6 months wait. By not giving the most effective therapy, we had a 5% compromise on survival. Now, the question of generic or branded, which one to choose. This is a very large study from China, 442 patients, and again it showed that those who had generic had as good outcome as patented drug, with the same depth of response, same PFS, and same survival. Therefore, today we're using in Houston generic imatinib therapy, and soon we will have as well generic dasatinib. So frontline therapy with several randomized trials all have shown that second-gen TKI can induce deeper and faster responses compared to imatinib. However, none of them has shown survival benefit, because we have a very effective survival therapy. So if your goal of therapy is survival, imatinib is a great option. No, if you aim to stop therapy, then second-gen TKI should be offered. No, one should be aware and concerned, and be aware that second-gen TKI can be associated rarely, but with serious adverse events, being lung injuries with dasatinib and vascular event with nilotinib. So here is a summary of the frontline randomized trial. Again, all have shown deeper, faster responses at 3 months with the second-gen TKI compared to imatinib. Less transformation, however, when it comes to PFS and survival, with the decision that dasatinib, NSND, nilotinib before bosutinib or high-dose imatinib, all of them did not, none of them has shown a survival benefit compared to imatinib therapy. Now, I'd like to highlight one serious adverse event with nilotinib, for example, at 10 years, the cardiovascular events. I remind you that those approved is 600 milligrams daily or 300 milligrams twice daily. With that, at 10 years, we've seen 24.8 cumulative adverse events, mainly vascular, mean 2.5% per year. This is why in a frontline, in somebody with a lung injuries, with a vascular injuries or risk for vascular events, I do avoid nilotinib. So when we compared dasatinib to nilotinib, there was no difference between the two. This is a study done in Japan, randomizing patients to either nilotinib or dasatinib. No difference whatsoever between the two arms. So efficacy-wise, they're all identical. Now, how do I choose my therapy in the front line? And again, depends on my goal. Generic imatinib is a great option, especially if you have expensive out-of-pocket expenses. Dasatinib is another option, 100 milligrams per day. Although I showed the data from MD Anderson make 50 milligrams daily, Bozotinib is another alternative, and nilotinib. However, keep in mind, I use a lower dose and escalate to avoid adverse event. If your goal of therapy is to improve survival, then any of these four options is a great option. High score disease, I do favor second-gen TKI. No, if your goal of therapy is to induce treatment-free remission, then I do favor second-gen TKI. So again, I remind you the choice of therapy depends on what you want to do, age of the patient, cost of therapy, aim, whether you want to aim for survival or TFR. If TFR is your aim of therapy, then you need to favor second-gen TKI. And finally, watch comorbidities and select the drug that interact the least and cause the least adverse events. So once you start therapy, monitoring is very important. You must induce a deep molecular response as early as possible. I'll do PCR every 3 months the first year, until MMR for 6 months and longer. Then I'll move to 6 months PCR. If the PCR is increasing, check for compliance, repeat your PCR twice before we make any move, repeat in 3 months. My gold standard for survival is a PCR of 1% or less, so I will not change therapy for a lower level of PCR. However, I will only change therapy if I have a PCR above 1%. MMR decreases risk of relapse but doesn't improve survival, and CMR is very important if your goal is to offer treatment-free remission. I check for mutations only in a setting of clinical failure, and the results finding should be interpreted in the context of alternative therapies available. So aim of therapy, survival or treatment discontinuation, treatment-free remission, and that we need to assess the long-term safety. Stopping TKI may allow you to deliver a safer regimen and no adverse event in the long run. And finally, if you want to stop therapy and use second-gen TKI at the beginning, at what cost? This is what we call treatment value or cost effectiveness. So some definition of deep molecular remission is essentially PCR below 0.01 or even better below 0.0032% international scale. They define MR 4.5, and then you need to shoot for deep molecular remission if you want to stop therapy. Ideally 2 years and plus, give you a chance of success 50% of TFR. However, if you want to optimize your TFR rate, then you need 5 years and plus of deep molecular remission. By doing so, we can improve the treatment-free remission to 80% and more. Here are summary of different data with STEAM1 Twister and STEAM Twister and S Freedom. You can see here overall half of the patient can have a treatment-free remission. Now, in S and D, of course, we've seen higher rate with nilotinib, although patients on imatinib therapy were taken off the study already. But if you look at the data from Germany, the CML4, you can see you need to have a deep molecular remission. And even with imatinib, the rate of MR 4.5 is 72%. So the difference between imatinib and second-gen TKI is you can get faster to deeper molecular response, and therefore starting counting for deep molecular response for 2 or 3 years, it can get you faster with second-gen TKI compared to imatinib therapy. So the EuroSKI was the largest trial in Europe done where we assess treatment-free remission. 728 patients were enrolled. They should have TKI therapy for 3 years and more and have an MR for 1 year and longer. They were offered a treatment discontinuation with very close follow-up the first year, every 4 weeks, then every 3rd month from year 2 and 3. We had the long-term results reported last year. Success rate is in the range of at 2 years of 50%. Mean half of the patients were able to maintain treatment-free remission. And however, most of them have been were seen the first 6 months, but we don't have a plateau here because at the long run, there's patient relapsing. The outcome does depend on how early the response is and how durable the deep molecular remission was before stopping at TKI, with the threshold with at 3 years having success rate of 48%. Here, a single institution experience from France, 15 years of follow-up. Again, early on, half of the patients did succeed to stop therapy. However, with the longer follow-up, after 2 years, 9 of the 65 patients were, did relapse. Therefore, that tells us we should monitor our patient carefully at the long run to avoid relapses and to intervene as early as possible. What matters for success is TKI duration and MR4 duration. But the question is why the different rate of success between 40 and 60%? Well, it does depend on a criteria for treatment discontinuation. In a Euroski trial, for example, we set the stage for MR and for at least 1 year. In a STEAM trial, we did MR 4.5 for 2 years and longer. Therefore, we had deeper responses and more durable responses, and that translates into a success rate that goes from 50% in a Euroski trial to 64% in 2 years with a STEAM trial. Therefore, you must keep in mind you need to have a deep response, as deep as possible, as durable as possible. So at MD Anderson, we look at the success rate, and we publish at the beginning that you need to have a CMR or 5 years and longer, and those are the 5 years of CMR had a success rate of 80-90% compared to 30% if you have a shorter duration of response. You look at the relapse rate, less than 2 years is 75%, with 6 years and longer, that dropped to 6%. We reassess our experience with a longer follow-up with 300 patients enrolled. These are the patients we assess at MD Anderson. Mainly, half of them are low risk, intermediate 38%, and they are receiving second-gen TKI the most, and these are patients in frontline therapy most of the time. And we look at the success rate, it does depend on a duration of deep molecular response. Those who had 4 years and 5 years and longer of deep molecular response, the red curve had a TFR success rate at 2 years of 85%. It goes up to 90% if you wait for 6 years. In contrast, if you have 5 years or less, your TFR rate is only 67%. And then once we look at the patient who they lost their response, we put them back on TKI, and you can see 81% of them were able to achieve a complete molecular remission with the time to CMR being 6.5 months. So bottom line is you need to have a favor second-gen TKI, have the deepest response possible for as long as possible, and then after that, you can offer treatment discontinuation. So here a table summarizing what do I do in Houston. I will offer treatment discontinuation in patients with a low intermediate risk disease, not high, quantifiable transcript to be able to follow my patient, chronic disease, never transformed, optimal response to TKI, not failure, TKI duration for as long as possible, 8 years and longer, not in somebody with 3 years of treatment, and you need to have a CMR or at least MR4, MR4.5, never for less than MR4. Deep molecular response duration of at least 2 or 3 years, ideally 5 years. And very important element is to be able to monitor your patient after treatment discontinuation. If you cannot monitor them, then you have a problem with compliance, and patient can lose their response to progress, and they will not be noticed or taken care of immediately. So how do I monitor post-treatment discontinuation? The standard ELN NCCN guidelines is to do every month PCR for the first year, then every 2 months the second year, then every 2 months in the year 3 and onward. At MD Anderson, I do PCR every 2 months the first year, then every 2-3 months the second year, then every 2 months the third year, then every 4 to 6 months thereafter. And I will not resume my TKI based on only one PCR result. I will check my PCR, repeat the test within 3 months, and if it's above 0.05 to 0.1%, then I will resume my tyrosine kinase inhibitors. Moving forward, what are we doing to further improve the TFR rate? We're exploring combination therapy. We did combine dasatinib and venetoclax. The results are still pending, but the study is completed. And the current approach today is to do dasatinib 50 milligrams per day with the cytarabine given orally at 35 milligrams daily for 3 days every month. The aim is to induce a deep molecular remission and offer treatment-free remission thereafter. So in 2022 and onward, we have frontline therapy being excellent, getting better and safer. Dose reductions are effective and safe in most circumstances. Dasatinib 50 milligrams per day and per 15. Treatment discontinuation is feasible, but better wait for a long, deep molecular remission, 3 to 5 years, if you want to improve your chances of treatment of cure at the long run. We have novel exciting TKIs. We're working on strategies to improve the TFR rate, mainly with the combination. And finally, patient comorbidities should be optimized. Thank you very much for your attention, and I'll be happy to join the panel for discussion. I'll leave you my email and my cell phone and office number if you need any questions. Thank you very much.
Thank you very much, Dr. Jabbour. Now the time is for discussion. We have kindly Dr. Dabaja and Dr. Riyad Faqih, also Dr. Jabbour with us now.
The floor is open for questions.
My question for Dr. Dabaja, I think in CAR T cell you mentioned, I think you would be able to decide about the response within 3 months. At 90 days is the most important landmark. So what about like 30, 60 days? Would it be predictive, or like day 90 is more predictive than?
Hello? Hi. Hello? Yes, sir.
So normally what we do is, there is certainly different cases, but in my opinion what we have found the best is to try to do a disease staging around day 30 as much as we can. Now, initially because of the probably growing experience at the time, we were more careful and trying to do it at a later time, but our approach right now is to do a PET scan at day 30. If a patient has a Deauville of 1 or 2 or up to 3, then the next one will be day 90. But if the patient still has residual disease, then I repeat it at day 60. And just to make sure, by that time I'm already planning for an allogeneic transplant if the patient is young. So day 30 for sure. If PET negative, then I repeat on day 90 to confirm. If still residual disease, I'll do day 60 and make sure. But in my opinion, the day 60 is the more determining one. By day 90, if it's still PR, it's too late. So day 60 to day 90, that patient already is preparing for an allogeneic transplant, if they can. If not, then we have some data being presented at ASH where we have looked at POLA BR, which can salvage few cases, but it's not durable response. So that's kind of our salvage regimen to go for an allo transplant. But the data we published with 5 or 6 other centers show that patients with who receive an allogeneic transplant, you can still probably save half of the cases. Still 1 year follow-up, so too early to say, but it looks like that's the best approach to salvage this patient. In the future, I think that we're going to look at novel therapies and novel targets for CAR T. So patients, for instance, like failed CD19 CAR T, we could use at other, like CD22, our own BFFR that we're going to be testing also.
Doctor, my question for Dr. Jabbour.
Yes?
Yes. Based on
hello, everybody.
Hi. Based on your presentation, you're avoiding the use of nilotinib as a first line based on the 10 years data, 25% risk of cardiovascular disease, and also you are using dasatinib 50 milligram. Do you think this will change for example, guidelines, LCCN guidelines, avoid use of nilotinib as first line and decrease the dose of dasatinib to 50 milligram, or we need longer follow-up or other studies, bigger studies?
Well, thank you very much for the question. Regarding nilotinib, we avoided but that is not a absolute contraindication. In fact, you choose your TKI based on patient profile and comorbidities. So somebody with hypertension, somebody with overweight, somebody with risk factors, I want to avoid nilotinib. So I don't think this will be part of any NCCN. They may select your TKI based on patient profile. So that will not change. When it comes to the Zatin 50 milligram per day, with the new recommendation, it's a small option about 50 milligram per day. I think 50 in our hands is really good option. Of course, we'll need confirmation from other groups. Don't think ever will be a randomized trial, although there's a small one done in Jordan with genetic Zatin 50 versus 100, and that is the closest we can get. In a study we did, most of the patients we enrolled them intermediate and low-risk disease. So I think we have good data for 5 years showing that 50 is a great option for this group of patients. So if somebody had a high SOPA score disease, I will still go with 100 and reduce the dose if need down the road. So I hope it will be part of ACCN. I think this is the standard of care, but it's coming from MD Anderson, single institution. People will have reluctance.
My question for Dr. Faqih, with now identifying subset of IGHV mutational status, would that have an implication on the treatment at this time point, or maybe do you think in future, would it affect, how would they treat those subset of IGHV mutational status?
Yeah, I mean, currently it's in practice, not in general practice. In academic centers, they would check for the stereotype of these immunoglobulin mutation and individualized treatment according to the results. But in general practice, I don't think it's soon. It'll take a while, to better classify these isotypes and their implication, specifically their implication in terms of therapy, like which stereotype would guide you to use venetoclax and which stereotype would guide you to use BTKs and so on. Or maybe which stereotype would tell you to use chemotherapy, though chemotherapy is off the desk in many institutions already. So it's not up to general clinical practice as of now.
I have a question for Dr. Faqih also. So I noticed in your presentation the absence of allogeneic transplantation as a treatment option. In your opinion, is that not an option anymore?
I've done 3 transplants over the past 2 months. So it is, first of all, how are you? I couldn't go to the MAM, and I'm happy to see you joining from US. Now, we do a lot actually here, specifically that we deal with a young population. As you know, 90% of the Saudi population are younger than 60. So these patients present younger with the CLL. They fail the treatment pretty much like others. And then you fail everything at the age of 50 or 45, then your only option is allogeneic transplant. So we still do it, still an option. You have to be very selective. Plus, the toxicity and the treatment-related mortality is problematic, but still it's an option on the table with good cure rate, despite the treatment-related mortality of about 20%. The other thing, or the other reason that we may be using more allogeneic transplant as compared to the States is our restricted access, to clinical trials and to the new molecules. Like I just transplanted, I did haplo on a patient who failed ibrutinib and venetoclax. And that's what I have. I have ibrutinib, BTK, venetoclax. Idelalisib is on compassionate use. The other new BTKs are not available. The new smaller molecules are not available. Sometimes we would get, a clinical trial where we can include some of our patients. But in general, we only have ibrutinib or BTKs in general and venetoclax. So this is the other reason we may still use allo more heavily than than in the States and Europe. Thank you.
I have a question to Dr. Jabbour out of curiosity. So, nilotinib and an incidence of cardiac toxicity.
Sorry, I think Dr. Jabbour left. He has patients.
No, I'm here.
Okay.
I'm here.
So, yes, those patients, the 25 to 30% who develop this cardiac toxicity for nilotinib, have you done any genetic studies on those cases? What is it that is unique about that 25% population?
This is a very important question, Mohammed. Thank you so much. As you've done in MDS, where we knew that patient with CHIP can have more cardiovascular events, trying to replicate this effort in CML, look for XL1 mutation, try to understand what's happening. We don't have solid data yet. I can tell you, for example, with ponatinib, which is associated with vascular events, we did see increase of mortality, not through only complication of the disease, resistance of the disease, but mainly to other, that's in CR. So we still struggling to understand, but it's a great question and we won't have an answer for it. We're doing sequencing on them, and we try to see if we can identify some chip-like picture that is associated with vascular event, but that is unknown till today. I hope to see you in the next few days, Mohammed.
Hope to see you soon also.
Okay, thanks.
I think we conclude this session. Thank you very much for attendance.
Thank you for the invitation. Thank you.
Thank you. Thank you.
Okay, today is a Friday. I think many of the speakers left. So now we have a meeting with Dr. Dabaja. We can sit around